Okay. Good afternoon from Tehran, and welcome to the last day of International Head and Neck Pathology short course. Today we will have 4 outstanding lecturers, and today's lectures are focused on malignant and premalignant epithelial lesions. Before introducing the first lecturer, I would like to remind you that if you have any comments or questions, you can type them in the chat box. Okay, our first keynote speaker is Professor Tilakratne. He is the professor of Department of Oral and Maxillofacial Clinical Sciences, Faculty of Dentistry, University of Malaya. He's been working as an oral pathologist for 3 decades and held many positions in the field of oral pathology. He is the past president of International Association of Oral Pathologists. Professor Tilakratne, we are so honored to have you here today, and we are loving to hear your presentation with the topic of premalignant lesions. Please, Professor. Please, Professor, the stage is yours.
Can you see my screen? Okay.
Yes, okay.
Good afternoon, good evening, everybody. First, let me thank the organizing committee for inviting to contribute to this very important and very well organized short course on head and neck pathology. Today, the topics are very appropriate, especially for Asia, because oral potentially malignant disorders and oral cancer, compared to anywhere else in the world, Asia comes #1. So therefore, I think it is very appropriate for us to discuss these topics. So I would pitch the talk at the postgraduate trainees level, because I know most of you are postgraduate trainees, and there may be medical and oral pathologists as well. Right, this is the outline of my lecture. So I'll be talking about definition and different types of oral potentially malignant disorders, and then I will spend significant time discussing the different issues related to epithelial dysplasia, and then the last part will be some controversial issues in relation to oral potentially malignant disorders. Well, you all know, let me get this here. You all know this subject so well. Now, we did not call oral potentially malignant disorders until 2005. In a meeting in London, after 3 days of deliberations, it was decided to change the term pre-cancer to oral potentially malignant disorders. Because as we all know, when we say pre-cancer, it is 1 stage before cancer, and you expect most of them to transform into cancer. It is not the case in the case of oral precancers. In fact, a minority of them only transform into cancer, right? So this is the definition of Opmd in the 2017 classification. Oral potentially malignant disorders are clinical presentations that carry a risk of cancer development in the oral cavity, whether in a clinically definable precursor lesion or in the clinically normal mucosa. Now, the group of us looked at OPMDs in detail in 2017. Now, last year, the latter part of the last year, another international group gathered in Glasgow and came up with a much shorter version of OPMD definition. It says any mucosal abnormality that is associated with the statistically significant risk of developing oral cancer. Right. Now, what are the oral potentially malignant disorders? So, OPMDs. Now, this is the list that you see in the 2017 classification. Now, you will be happy to hear, now we have just started doing the new edition of WHO classification, and it will be out perhaps toward the end of the year. Don't expect much changes in this area, because after 2017, we do not have significant literature added in terms of new scientific research. So these are the historical list of OPMDs: erythroplakia, erythroleukoplakia, then leukoplakia, the commonest one of the commonest ones. Then oral submucous fibrosis. If you look at South Asia, by far that is the commonest OPMD. Then rare things like dyskeratosis congenita, exceptionally rare syndrome, the hereditary condition. Then smokeless tobacco keratosis, palatal lesions associated with reverse smoking that we don't see in many countries, especially we see that in some parts of India. And the chronic candidiasis. Now here you can see it says chronic candidiasis, not chronic hyplastic candidiasis or chronic candida leukoplakia. We will discuss those things later. Then lichen planus, DLE, syphilitic glossitis. It is more historical than real because we don't see syphilitic glossitis nowadays. And then only for the lip actinic keratosis. Now, as clinicians or pathologists, now this is what we are seeing. If you take the two commonest OPMDs, the oral submucous fibrosis and leukoplakia, now clinicians are not in a comfortable position to decide what patient of their follow-up patients is going to transform into cancer, right? They do have clinical parameters to decide, but the clinical parameters alone are not helpful and they are not reliable either. So, as caring health professionals, our aim is to reduce the malignant transformation. Even better, if we can identify OPMDs early stage, I think the oral cancer incidence can be reduced to a great extent. But this is the reality. Now, irrespective of how developed the countries are, still we see stage 4 cancer patients come into hospitals. Now, especially in South and Southeast Asia, about 70% almost of oral cancer patients come to clinicians at stage 3 or stage 4. That is not good enough. Only 5% of our cancer patients are seen at clinics at stage 1. So they, of course, end up with very radical treatment. You know the, the implications of this kind of a radical treatment. The patient's social life, the cost to the hospital, the health system, etc. It's enormous. Right. When we look at the histologically, as pathologists, this is what we are interested in. And you can see the normal mucosa, and then you get leukoplakias, so white patches without dysplasia. Then you get mild degree of dysplasia, just see the basal area. Then you get moderate epithelial dysplasia, severe, and then cancer. Now you see again, we are not in a position to help clinicians 100% because we cannot tell them, look now, this patient is definitely going to have a chance of getting cancer. True, when you go down in the ladder up to severe dysplasia, the chance of malignant transformation increases. But still, when it comes to other areas, we do not have enough histopathological predictions to make by looking at the existing dysplasia grading. So therefore, we know we get without any OPMD from normal mucosa, de novo cancers, and with very little dysplasia or no dysplasia or slight dysplasia in conditions like PVL, we get very high malignant transformation rate. So as pathologists, by looking at the histological features of OPMD, we are not in a good situation to tell the clinicians that this patient needs this follow-up and that patient needs that follow-up. We are not in a position to do so. If you look at the molecular events, so we looked at the world group, all the molecular changes in Opmd some time back. But again, what we were able to do is we could recognize the potentially malignant disorders, and some cohort of those patients are molecular-wise, biologically they are benign. They have no potential to transform. And some of them are molecular, biologically, they are pre-malignant, right? So some of them go on to develop dysplasia, but again, the problem that we face is not all the dysplasias progresses. They don't progress, not all the dysplasias progress into cancer, and only some transform into cancer. So you see now this is a jigsaw puzzle where we are in a situation where we cannot decide what particular patient is going to get cancer when we look at these things in isolation, right? If you want to get a better idea, at least at the moment as it is now, we need to combine histopathological features, clinical features, together with available molecular aspects. Because as it is now, other than the loss of heterozygosity and ploidy status, we don't have better markers for epithelial dysplasia grading. We did a review by looking at 270 articles some time ago, but still we could not find more than that. So what's leukoplakia? Now, leukoplakia is predominantly a white patch which cannot be classified as any other definable lesion. That is the classification of leukoplakia. Now, you see these are our patients attend to our clinics. Now, very altered depapillated tongue. Now, this is a case of actually submucous fibrosis having leukoplakia, commissural leukoplakia, again leukoplakia on the tongue, and varying presentation, right? Little verrucous looking leukoplakia and leukoplakia with red areas, white and red areas, it's erythroleukoplakia. So there are so many different presentations of leukoplakia. Of course, depending on the type, especially whether it is homogeneous or non-homogeneous, we know the transformation rates are different. So another way to look at leukoplakia is by classifying them as homogeneous, non-homogeneous. They are the speckled leukoplakias or erythroleukoplakias. And the very important entity that I'll be spending a little time on this later, the proliferative verrucous leukoplakia. And palatal keratosis with reverse smoking, as I alluded to earlier, you don't see that in most countries, but commonly seen in the Andhra Pradesh of India, and also probably some tribes in Africa as well. Now, this is what I told you in terms of leukoplakia. This is the very problem we have. Now, we are not in a position to decide by looking under the microscope, by looking at histopathology only, which case is going to transform into cancer, which one needs surgical treatment, which one does not need surgical treatment, etc. We are not in an accurate, 100% accurate situation to do so. So therefore, those are the areas where we need to look for answers that I will come back to that later. Now, if you look at leukoplakia, the transformation rates, it's about, if you look at 95% confidence interval, it's about 0.69 or 0.7 to about 2%, right? That is a global. But if you look at, take cases only from South Asia, that is definitely going to go up. So the annual oral cancer incidence due to leukoplakia is between 6 to 29% per 100,000 population. So that's again a significant number. Some of the facts that we all know about leukoplakia is these things were mostly coming from Mayana's review some time ago, systematic review. The surgical intervention does not appear to prevent Opmd from developing malignancy, right? So that tells us a lot. We know with experience, as pathologists, some leukoplakia surgeons excise them over and over, but still they come back. Clinical type of leukoplakia and size are related to malignant transformation, right? That's the very true. Like speckled leukoplakia has a higher transformation rate over homogeneous leukoplakia. And also the leukoplakias which are larger than about 200 square millimeter, that is 2 by 1 centimeter, have a high chance of malignant transmission. That has been shown. Site, although I say site here, some sites we know are having little higher transmission rate. But the only thing is when you take PVL into context, but even the sites that we usually don't see, the cancer formation you see with PVL like hard palate, etc. and gingiva. The demarcation, the presence of epithelial dysplasia, surgical interventions appear to be insignificant. So that is the reality. So therefore, we need to have new treatment modalities to be developed if we are to prevent malignant transmission of oral premalignancy or oral potential malignant disorders. Now, this condition, the PVL, we popularly call it proliferative varicose leukoplakia. Now, this is a condition that was described in mid-1980s by Hansen et al. And they said it's initially present as a white plaque lesion that eventually becomes multifocal and exophytic. So that is the nature we all know. Now, what is important in PVL is its high recurrence rate and very high malignant transmission rate. I told you at the beginning, it does not have much dysplasia, but they transform into malignancy. So that is why I said as pathologists, histopathologists, we are not in a position to tell them by looking at histology alone, the malignant transmission potential of PVL. So that the only thing that we know is probably there are more molecular changes in PVL than the phenotypic changes that we see under the microscope. Now, the PVL we know is common in females and of course the elderly females. Now, in short, if you see elderly female patient with multiple white patches in usually unusual sites, mainly like gingiva, the hard palate, dorsum of the tongue, and those are cases you should suspect about PVL. Now, etiology of PVL is not understood fully, right? So we don't know exact etiology of PVL. Common etiological agents for Opmd, oral cancer, such as tobacco and alcohol, do not appear to be associated with PVL. And also some researchers have worked on the role of human papillomavirus mostly, and also EBV. But again, the results are not solid. So therefore, in short, the PVL etiology, by and large, we do not know at the moment. Now, PVL, as I alluded to earlier, they start like flat white keratotic lesions, and they become diffuse and multifocal, and they progress horizontally and becomes exophytic or varicoid surface. Sometimes in between the white areas, you can see erythematous areas. Now, invariably, most of these cases either turn into varicose carcinoma or into varicose squamous cell carcinoma. One of our cases, now this patient presented as a small white patch on the palate, and over the years, you see it has extended to a fair amount of the palate covering and going into buccal mucosa as well. So that is the nature of proliferative varicose leukoplakia. Now, if you want to compare that with histology, so the flat white patches to start with, and they become slightly varicose, and they become very verrucous and papilliferous looking. And after that, they either become verrucous carcinoma or squamous cell carcinoma. So that is the natural history of PVL. So it's a condition that we find it very difficult to manage. Fortunately, this is not common. Now, this is the classic example of PVL where we do not find much difficulty. Now, if the clinician sends her the biopsy with the proper clinical history, say in multiple white patches, preferably in uncommon sites where you get conventional leukoplakia, and when you look under the microscope, you see this lamellated, mostly orthokeratine on the surface, and with a nice demarcation, unlike other normal leukoplakias. And the most important feature is with very little cytological atypia. So that is the hallmark of PVL. With the clinical history, if you get this kind of picture, then you can make your mind that it's a PVL. So it is becoming verrucous, this picture, that's still not the very verrucous, but usually the cytological atypia is again minimal. Now, you need to remember, as I told you, it is important for us to get the clinical history, but there are so many conditions which mimic the appearance of PVL at early stage. I told you, even PVL early stage, it has to start somewhere, as probably as one white patch or two white patches. So this example is a lichen planus, but it has little exophytic appearance here and there, so it mimics the appearance of PVL. So I will come to that PVL and lichen planus later on. So we know lichen planus has its characteristic histopathological features. We will be discussing that in detail later. Another condition that we need to consider with PVL is now this. You see, it's irregular appearance, slightly exophytic keratin in a traumatic lesion. Right? So again, the lesions of traumatic keratosis can look like PVL. So when we look under the microscope, we have some diagnostic features for traumatic lesions. We know where you have this shredded appearance on the surface due to trauma, and then there is no cytological atypia, and more importantly, this traumatic keratosis, you do not find any inflammatory infiltrate. And this is another example where PVL come into differential diagnosis. Now you can see it is on the alveolar ridge. This is called benign alveolar ridge keratosis. Again, it mimics the appearance of PVL under the microscope as well, unless you get proper clinical history. Now here, you all know this is this appearance, this grayish white appearance you get when you keep smokeless tobacco pouches in the buccal or labial the sulci. And this is again a condition that you need to be careful when you diagnose PVL, because it can be in several places as well. And some examples of normal leukoplakia can also look like PVL when you look under the microscope, unless you get the proper clinical history. Therefore, in short, you need to get the proper clinical pathological correlation before diagnosing your PVL cases. Now, this is a case of PVL. Now, when you look at it, you might think, oh, is it PVL or is it lichen planus? Right? Remember, this is a mistake that we all make with the first biopsy of PVL. And the clinician, to be fair by the clinician, he also doesn't have much information to give to us. And he says it's a white patch or two white patches. And we see this almost band-like infiltrate or interface dermatitis like lymphocytic infiltrate, and very little cytological atypia or no cytological atypia. So you tend to diagnose this as lichen planus. That is a common mistake. But after some time, the clinician will call us, you tell us, no, this patient is developing more patches, now they are becoming more exophytic and verrucous looking, etc. Then only we'll go back and look at it. then we know we have made a mistake, but it's not lichen planus, but it's PVL. Now, the diagnostic criteria put forward by this group, leukoplakia in more than 2 different sites, frequently gingivae, alveolar process, and palate. Now, these are not the areas where we usually see leukoplakias. At least some stage, the verrucous, some places, existence of verrucous areas. If you find you are lucky, very early lesions, you might not get it. And the lesions spread into adjacent areas. And recurrence, if there is previous history of treatment. And histopathologically, of course, it shows the features that I showed you earlier. The minor criteria, leukoplakic lesion that occupies at least 3 centimeters, female patients preferably, non-smoking patients, most of them are. It doesn't mean that you don't get in smokers, but most are non-smokers. And this is evolved over a long period of time. Now, the palatal lesions in reverse smoking, the very dangerous condition that, they keep the burn inside of this cigar inside the mouth. It causes not only the effects of tobacco into the palate, but burning as well. So they develop leukoplakic lesions as well as erythroplakic lesions. Now you see the white border with more like erythroplakia. They have a very high malignant transmission rate. Now the erythroplakia, now this lesion almost synonymous with oral cancer. Now my colleagues who have been reporting for long years know when you get a query erythroplakia from your clinicians, large majority of them are cancers. In fact, about 50% of them are cancers, 40% of them are severe dysplasia. And I can't remember a case diagnosing as mild dysplasia when I get the biopsy of erythroplakia. So you see very fiery red lesions. Of course, red patches are very common inside the oral cavity due to trauma and inflammation. But once you exclude those conditions, you are left with a red patch that is erythroplakia. So we do not have much studies on the natural history of erythroplakia because this is very rare. If you ask me what is the Opmd with the highest malignant transmission rate, the answer is erythroplakia. Now this is what we see when we look under the microscope. Why it is red? Now you can see the suprapapillary atrophy here. The underlying corium extends almost up to the epithelium, showing us the underlying vasculature. So very atrophic area. So hence we see the red color. And you can see full thickness dysplasia in most cases of erythroplakia. Now we move to the most common Opmd in South Asia and parts of Southeast Asia. I don't know whether the beetle chewing habit or areca habits exist in Iran at all. But this is a disease that we have studied in detail, the detail. Now, those who want to read about oral submucous fibrosis, we have produced one full focus issue on Triple Journal on submucous fibrosis in 2016. If I remember correct, it's August issue of 2016. Now, this is a fascinating disease with a lot of interesting attributes. Now, this is a potentially malignant disease, and it's a chronic inflammatory disease, you see. Although we have no answers to a lot of things in submucous fibrosis, still it is a very common pathological process, chronic inflammation. Now, most of the morbidity related to these fibrotic changes, their clinical features and the signs and symptoms are due to fibrotic changes and atrophy of the surface epithelium. But this atrophic epithelium, remember, becomes dysplastic and turn into cancer. Now, fascinating disease, why I said that way, because the disease is mostly in the underlying corium, but you get the development of cancer on the surface epithelium. Now, etiological factor, now we know there are no etiological factors as said, but it is only one etiological factor, that is arecanut. The chemicals present in mainly arecholine in arecanut together with other chemicals like guaifenesin, guaiacholin, and also the polyphenols like the tannin, etc. So whatever the form of arecanut you use, they all have the ingredients. They all can cause oral submucous fibrosis. Now, the worrying thing is now it has been identified that arecanut contain definite 4 carcinogens, 2 coming from arecholine and 1 each coming from guaifenesin and guaiacholin. Now, if you look at the volume 85 of IAC monograph, you can see arecanut, all about arecanut in that monograph. What are the clinical features? The clinical features are the burning sensation, that is because of the atrophic epithelium mostly, the barrier properties are lost. So they find it difficult to take spicy food. The mucosa is very rough. You can see here, it doesn't look smooth at all. In fact, it is like almost like a leathery feeling. Early cases can get vesicles in the soft palate area. Mouth opening is restricted because fibrosis extends into muscles, and for the same reason, they can't move their tongue either. Now, these are the histopathological changes that we see under the microscope. The early cases of submucous fibrosis changes are very subtle, very difficult to identify. So, clinical features are important. So, you see a little bit of fibrosis there. But when the disease advances, you can see more and more fibrosis settling in. And when it go even further, now you can see the fibrosis creeping into muscle, right? This extending fibrosis, we call creeping fibrosis, going to surround these muscle fibers, and then the muscle fibers are lost completely. They do not perform their function. So that is why they can't open the mouth, they can't move the tongue, etc. Now you can see the patient can't open the mouth. When you look at now, epithelium is completely now atrophic, so they get burning sensation to spicy food, etc. And no ridges at all. And the fibrosis extending in between muscle, you see what has happened to muscle. All the muscle fibers have been replaced by fibrous tissue, and little bit of muscle fibers are just lost in the jungle of fibrous tissue. So therefore, the muscle cannot act in the way that we want them to act. So therefore, they get all these problems, can't open the mouth and can't put the tongue out. The precancerous nature of this disease was described by Paymaster in 1956. In fact, about large cohort, 1/3 of his patients, according to his original paper, transform into malignancy, which is a much higher rate, but we don't see that much of malignant transformation. Transformation is around 7 to 8%. But epithelial dysplasia in submucous fibrosis changed from 7 to 26%. Now, dysplasia grading is a different story when it comes to submucous fibrosis. We'll try to discuss that later on. And these patients, about 25% of OSF patients may develop leukoplakia. You see the one Opmd over another Opmd, so therefore their transmission expected to be higher. So these are the leukoplakia that you get developing in the background of submucous fibrosis, unusual sites for leukoplakia. Even you see the anterior part of the tongue. So they are not common sites for a non-OSF patient to develop leukoplakia. Malignant transformation rates are varying because the study designs are very different from one to the other. Follow-up periods are different. The criteria, recruiting criteria are different. So therefore, we have a very massive range or difference in malignant transmission rates. Now, I told you the problem of dysplasia. Now, this is, you see, the normal submucous fibrosis histology. Fibrous submucosa, and very atrophic epithelium. Now, very early cases, you start to see little hyperchromatism of the basal cell layer. And then you see you get very tiny buds of epithelium. In another context, we might not consider this as a sinister feature or dysplastic feature. But you see, if you leave them alone, so you will see more and more these little buds appearing. So this is important because for an epithelium like this, very atrophic epithelium, to get very little buds of epithelium looks significant. Now you can see another feature when this happens. Now this very hyalinized stroma starts to get tiny blood vessels, right? Neoangiogenesis in order to support the dysplastic cells. Now you see very hyalinized mucosa, right? Very atrophic mucosa, completely hyalinized. And these are the early changes. You see, this is a good example, but not all the cases are not like this. Now you see hyperchromatism developing in the basal area. And then more and more dysplastic features, they get even more features with time, and they develop oral cancer. Now, what are the risk factors for malignant transformation, especially leukoplakia, and also it's common to some other cases as well. According to most studies, the female gender has a high risk of malignant transformation, but according to some Indian studies, it is the other way around. Longer the duration of leukoplakia, higher the chance of transformation. Leukoplakias in non-smokers, idiopathic leukoplakias have a high chance of transformation. The sites such as lateral border of the tongue and floor of the mouth has a slightly higher chance of transformation. I told you the size more than 200 square millimeters in size have a high chance. Speckle leukoplakias and the presence of epithelial dysplasia, especially higher grades of dysplasia, have a high chance of transformation. I told you this, the two molecular features, DNA aneuploidy and loss of heterozygosity, perhaps tell us when those two are present in a Opmd, probably they are on their way to produce oral cancer. Now, this is our friend. Yesterday, you listened to Jerry. Jerry's paper in 2006, he graded the potential, malignant potential of Opmds, erythroplakia at the top, PVL, reverse smokers, OSF, etc., etc. Right? So this is helpful for clinicians to plan their follow-up. Now we'll move on to the different issues related to epithelial dysplasia in the second part of the talk. Now, these are some of the problems we all as pathologists identify when grading epithelial dysplasia. There is very significant inter-examiner variability. Even if you look at the same lesion, same lesions blindly in another day, you will see you grade them differently. So the reproducibility of individual features is again very difficult between pathologists and also within a pathologist as well. So that again a big drawback in dysplasia grading that we have. Then some dysplasia, some epithelial dysplasias, we cannot say quantitatively this part is dysplastic. It's when you look at the epithelium, it is more qualitative assessment. There are factors which exaggerate dysplasia grading. If we overlook that, we get into a problem like the presence of Candida. And more important, this is what the clinicians are worried about. The dysplasia grade in the present 3-tier criteria does not in line with the clinical behavior and malignant transformation in terms of the grade that we give to them. So there is a problem. Because in other words, we do not tell them the biological significance of our grading because we do not know the biological significance of individual the dysplastic features. Now, the grading does not reflect the clinical extent or severity of the lesion, especially in vergopapillary lesions that we see in the background of submucous fibrosis. I will show you some of the pictures. Now, different people have tried different grading systems. You see from 1969, the famous photographic method by Smith and Fimberg, our forefathers of the oral pathology, and then down Odell and myself, we also tried to come up with a grading system, but we also could not. And last one is 2017. And now we are in the process of coming up with the new classification, but don't expect much changes in that in terms of dysplasia grading. Now in 2005, this is the definition. When architectural disturbances is accompanied by cytological atypia, we apply the term dysplasia. And also in 2005, this term SIN or squamous intraepithelial neoplasia, like in the cervical SIN, cervical intraepithelial neoplasia was introduced, but not many people used it, and it is not reliable either. Now, this is the WHO classification 2005. So we had the 5 years in a dysplasia classification. You see, having hyperplasia is again not acceptable. Now, SIN 1, SIN 2, and SIN 3. So this was not used by many because it is very difficult to apply to oral epithelium, not like in the cervical epithelium where you get uniform histology throughout. Now we looked at, again, Odell and myself, we looked at whether this SIN business can be applied to oral cavity, but we didn't call it SIN, we call it OIN, oral intraepithelial neoplasia. Now you see when we look at that with 3-tier system, huge difference. Now when we say OIN 3 or SIN 3, some of them are severe, some of them are moderate, some of them are even mild. So therefore, it's same with OIN 1 and OIN 2. We concluded that this OIN 1/3 business is very difficult to apply reliably to oral epithelium because morphology is different from one area to the other as well. So these are the separate features in the 2005. Then we came up with 2017 classification. And there we gave a little slightly different definition. Oral epithelial dysplasia is a spectrum of architectural and cytological disturbances. They occur as a result of accumulation of genetic changes. And these cases with epithelial dysplasia has a higher chance to progress into malignancy. Now, we changed the features a little bit. Now, we all know the loss of epithelial cell cohesion. Many years ago, we used to recognize that as a dysplastic feature, but that disappeared. But we reintroduced loss of epithelial cell cohesion into dysplasia grading in 2017. We know it is important. And also, the high risk and low risk 2-tier system, there we count the number of features present. So when we do that, if there is repetition of features, then we are going to double score. So in that scenario, in that context, we remove increased nuclear size from cytological features. We left with 8 architectural disturbances and 8 cytological atypia features. Now this, some work we did some time back, the lack of cohesion of cells. Now you can see, now these cells are falling apart. They are no more in harmony with the adjacent cells, but they can still survive without getting died, like in the case of vesiculobular disorders. No sooner they lose their desmosomal junctions, they are dead. But here it is not the case. Probably they are producing their own extracellular matrix. So this is heparan sulfate proteoglycans produced by epithelial cells in the dysplastic epithelium. So they survive probably with their own mechanisms. Well, now this is what we came in 2017, mild, moderate, and severe. And of course, all the severe cases are lumped into high grade. But this is where the problem is. Some moderate cases are high grade, some are low grade, but most of the mild cases are low grade. So therefore, it's still not a very satisfactory system. And to recommend only this, we do not have enough research. We expected people to grade all the dysplasia cases using both systems after 2017 and to come up with some good data, but it has not happened. So still, we are not in a position to decide we can use only this. It is definitely, we do not have good follow-up studies at the moment. So if we need to have a good grading system, most important thing is it should tell the clinicians what cases they can wait and watch and what cases should be treated. And the grading system should be reproducible, minimizing intra and inter-exam variability. And even more importantly, we should have a biologically significant grading system where the lesions with higher malignant transformation can be identified. That is, again, not the case to a satisfactory level in the present grading system. So this is the present grading system. If you apply present grading system criteria, now you see even experienced pathologists will struggle now to say whether this is dysplastic or not. Now most people will agree there is some changes in the basal area here, here too, and most people would agree it is going into middle third, but some people might say it is not, it is only in the lower one third. Here you can see the cytological atypia is extended to superficial areas. So especially low end of the spectrum of dysplastic lesions, with this current grading system, we have a lot of inter and intra-examiner variability. Life is easier for a pathologist if the cases are like this. It is never the case like this. Now, just low one third is dysplastic. We know it is mild. It goes into that area. It is moderate. When it is almost full thickness, we call it severe epithelial dysplasia. But sometimes it is allowed. Now, when you look at this, now the upper part of the epithelium is maturation is all right, differentiation is all right. But if you look at the lower part, you see loss of cohesion of cells, and look at the mitosis and high degree of cytological atypia. Now, most people upgrade this kind of lesions from moderate to severe. Now, if we have things like this, our life is easier. There is no argument, 100% agreement, full thickness dysplasia, it is severe epithelial dysplasia. Now, the problem is, as I told you, these individual 16 features, 8 cytological atypia and 8 architectural disturbances, a huge number of features. So that is one of the reasons why there is a lot of disagreement in terms of inter and intra-examiner variability. Now, Paul Spade's group has looked at the most agreed features, things like mitosis, that is the normal mitosis, bulbous retreat, pleomorphism. Those are features which can be reproduced easily. Now you can see this drop-shaped ridge. Now these are, for any pathologist, if you see that, that is reproducible. But whether that kind of features we should keep in the dysplasia grading for future new grading systems. But we still don't know what the biological significance of this drop-shaped ridges are. So that we need to research and find. Abnormal superficial mitosis. So these are, all the pathologists can recognize them as mitotic because there is no problem. But some features are difficult to comprehend by different pathologists. When we say loss of stratification, to some extent, not complete loss of stratification, difficult to have agreement. Loss of polarity of basal cells, I don't know whether it should be there in the features. Nuclear pleomorphism, atypical mitotic figures, the mitotic figures of prophase can be recognized as abnormal mitosis, etc. Nuclear hyperchromatism, right? So these are the features. I will run through these things because you all know this. You see the loss of polarity, very subtle, so not always we can reproduce that. Nuclear hyperchromatism, you see that area is more hyperchromatic, this area is not that hyperchromatic. Now when we grade these things by different pathologists, the agreement will not be great. Atypical mitotic figures, when you have this X or Y shape, it is easy, but when you have this kind of figures, so sometimes when you don't have a good section, it can be misdiagnosed as prophase mitotic figures. Now these, what I said, qualitative versus quantitative, it looks not normal, but you cannot pinpoint and identify all the architectural disturbances and individual features of cytological atypia. To make it even difficult, there are lesions which mimic epithelial dysplasia, right? So vitamin B deficiency, we know that can cause cytological atypia mostly, together with some architectural disturbances like disturbed maturation. Regenerative atypia at the edge of ulcers, you need to be very careful. These are very common mistake that young pathologists make. So we need to be very careful because regenerative changes of the epithelium with high mitosis, hyperchromatism, those things are there at the edge of ulcers. And chemotherapy can also give rise to changes. Now you see now these from the edge of the ulcer, you see the budding retis and they are little hyperchromatic. But it does not, it is not dysplastic. Now you can see the one clue to this is when you look at the underlying corium, you have granulation tissue, not normal immune response like in other dysplastic lesions. Now last part, very quickly, I will go through a little faster, the controversial issues in relation to Opmd. Now we have issues I alluded to in oral submucous fibrosis, dysplasia grading, verrucous hyperplasia, lichen planus, lichenoid dysplasia, then chronic hyplastic candidiasis or Candida Albicans. So these are areas where we have some controversies. Now these controversies come because of these things. There is subjectivity in evaluation of criteria, lack of calibration of use criteria. They're just subjective, not objective. And if you look at this now, I'm not going to spend time on this. I told you now, not many pathologists will recognize the early changes of oral dysplasia in oral submucous fibrosis. I showed you this very early, very tiny budding. They are significant, so we need to consider them as dysplastic features like that. That's very slight hyperchromatism, but you need to remember this the origin of this is from very atrophic epithelium. That is why we need to consider even this slight cell crowding as they are going into this dysplastic stage. Now these lesions, now when you look at very significant exophytic lesion, large exophytic lesion inside, and you see when we take the biopsy, this is the histology. They are very exophytic lesions with very little dysplasia, very much like papillomatous or verrucous hyperplasia look. But clinicians always say it looks like clinically cancer. Now here, all these patients, one thing is common, they are all submucous fibrosis patients. Now you see even from this patient, this is the biopsy I had. Sorry for the quality of the slide. There is no invasion in the many sections that we got at all. To make it worse, even dysplasia is very little. So we don't know the reason for this. So this is we describe this entity as exophytic verrucous hyperplasia in Asian consortium, but still it has not been accepted widely. So we do need more research on this area because we don't know why this happens. Probably fibrous corium does not allow this to go endophytic. So therefore, probably it is going exophytic. We don't know. So we need research on that area. Now, lichen planus, lichenoid reaction, lichenoid dysplasia territory. Now, if you have this clinical picture and your clinician tells you it is a bilateral lesion, it has reticular pattern or other clinical types of lichen planus, now you are comfortable, but you need to consider the differential diagnosis of lichen planus. We all can make mistakes. PVL, I told you, I described the interface dermatitis looking features in the PVL and lichen planus both. Lichenoid reactions due to drugs as well as due to amalgam. There are subtle histopathological differences, but the time does not permit me to describe all that. And DLE, graft versus host reaction, and chronic ulcerative stomatitis. Of course, lipositic response to epithelial dysplasia and mucous membrane pemphigoid. Now, they all can look like lichen planus depending on the given clinical scenario. So therefore, we need to be very careful when we diagnose lichen planus, although it's a very simple, straightforward diagnosis. Now, just to show you, now this is a case of lichen planus. If you I show you the low power, it's a band-like infiltrate, and epithelium is separating from the underlying corium, almost looking like mucous membrane pemphigoid. So you need to remember, of course, there are various things. Immunofluorescence will be helpful for MMP separation, and chronic ulcerative stomatitis will have intracellular dot positivity of IgG and C3. So likewise, there are differences that we can identify, but still, when it comes to lichen planus and lichenoid reaction, whether it's drugs or amalgam, it is next to impossible, some cases, for you to diagnose. You see now, this is, if you have the clinical history saying it is nice bilateral lesions, reticular pattern, etc., when you see this picture, you are very comfortable. You see this band-like lymphocytic infiltrate extending into basal cells, attacking them, and apoptotic bodies. And there the apoptosis and these hitis side by side undergoing apoptotic or liquefactory degeneration, forming almost like sawtooth appearance, which is not common inside in the oral cavity, and some areas early colloid body formation, etc. Very characteristic features. Now, when you have that, when the clinician tells you all the clinical history, now how I give the diagnosis report is, I would say, provided the clinical history is very convincing, histopathological features are consistent with the clinical diagnosis of lichen planus, right? But you see now, lichenoid reaction can look like that as well. But classic lichenoid reactions would look like this. Now you have lymphocytic infiltrate admixed with plasma cells, and more importantly, you will have plasma cell perivascular infiltrate like that. So when you have that, you know it is more likely a lichenoid reaction. You look for amalgam restorations or drug history or whatever. If that is there, you can say the clinician has given that history, you can say these histopathological features are consistent with the clinical diagnosis of lichenoid reaction. But more often than not, our bottom line, when the clinical features are not 100% given, we tell these histopathological features are consistent with either lichen planus or lichenoid reaction in the appropriate clinical setting or appropriate clinical context. I advise young pathologists to do that, then you are safe. Now, you see now this patient, the biopsy from a bilateral reticular type, almost lichen planus, but it looks like lichen planus, low power view as well, and the high power also. Now, you see, when you look with the high power, now the epithelium, instead of undergoing apoptotic change, some part, this is not the whole area, some areas classic lichen planus. Now you see budding looking retis. Now this doesn't look good, right? So these are the cases with the correct scenario, correct background, pathologists call lichen planus with some degree of dysplasia. Some people believe that these changes are due to chronic inflammatory infiltrate that you present in the underlying chorea. Now these two cases are from leukoplakias, two leukoplakias. Now you see this case, single lesion. Now you see how it looks like a band-like, right? Very much like a lichen planus, right? But when you look at it, there is some degree of cytological atypia, very subtle degree of cytological atypia. Now, if the clinical history is not the proper, some pathologists would say it is lichen planus with dysplasia, and some people will call it lichenoid dysplasia. And if you look at this, again, keratotic lesion, and you see some degree of cytological atypia in the lower part of the epithelium band, like almost lymphocytic infiltrate or lichenoid infiltrate, but people tend to call it lichenoid dysplasia. But I personally do not like that term. A lot of pathologists do not like that term. Now, this is a lymphocytic infiltrate, the immune response due to the dysplastic changes taking place in the epithelium. These are conventional dysplasias having some immune response. Then you might ask, why not all dysplasias do so? Answer, we don't know. But I do not encourage the term lichenoid dysplasia, but I call them as keratosis with some degree of mild or moderate dysplasia. But we describe this immune response separately. Perhaps these lesions will have a better prognosis. We do not have enough research on these areas. Chronic hyperplastic candidiasis or candidal leukoplakia. Now, the distinction between candidal leukoplakia and chronic hyperplastic candidiasis, remember, is not clear. Now, the term candidal leukoplakia was described by the Pimborg and I think share in 1960s. But still people use this term. Sometimes some people think they are synonymous. Now the causal relationship of Candida to this lesion is almost certain, because when you treat with antifungal agents, there is improvement. Right? The very recent systematic review by Shukla, they had only 3 studies on Candida Leukoplakia, and see the malignant transformation rate is very different from 2.5, 6.5 to 28.5. So that tells us that the consistency of calling these things as Candida Leukoplakia or chronic hyperplastic candidiasis may not be very accurate. So we need to have uniform criteria to diagnose these lesions. You see, when Candida is present, this is the problem. Now, when you have Candida on the surface, the dysplasia, dysplastic features can be exaggerated. Very large number of fungal hyphae. You see what happens when there is fungal hyphae. You get more dividing cells. The basaloid compartment can get increased. You get mitotic figures. They can look like hyperchromatic. And therefore, my advice is do not give a grading, definite grading, if there is a lot of Candida in Leukoplakia biopsy. So you comment on saying that there is dysplasia, but proper grading of dysplasia cannot be arrived at with the present biopsy, and therefore give a course of antifungals and do a rebiopsy in order to grade dysplasia correctly. So that is the safe way of doing it. Now, of course, the people have found various attributes of Candida albicans as a carcinogenic agent. It produces carcinogens to some extent. There is evidence, and of course, it can metabolize procarcinogens, and also, more importantly, it can convert ethanol into acetaldehyde. We know acetaldehyde is a carcinogen. The Candida can do that. So the Marinas group has shown that as well. And also, more importantly, it can induce chronic inflammation. We know the connection between chronic inflammation and cancer in general. So last 1 or 2 slides. Now, do we have genetic markers to recognize dysplasia correctly or the malignant transformation? As I told you, but there are a lot of molecular markers predicting malignant transformation have been reported, but most of them are not reliable. The most promising marker, as I told you, LOH, mainly in chromosome 3p, 9p, and also 4q and 17p. But as I told you earlier, ploidy status is another thing that we need to consider when predicting malignant transformation. So the reality is most dysplasias never progress into invasive cancer. Advance the degree of dysplasia, as I have been telling you, the higher the chance of getting malignancy. Global transformation rate of leukoplakia is around 2%. OED, when you follow up epithelial dysplasia cases, the chances of transformation is around 12% according to the systematic review. OSF, it is around 8% the transformation rate. Therefore, my dear friends, for a better grading system, we need to have more and more research. So I expect all of you to embark on research, especially those people who are in South Asia, because this Opmd is a big problem to us. Now, we need to use more reproducible histopathological features for a grading system in order to avoid inter- and intra-examiner variability. And we need to identify the more biologically significant features, right? So we do not recognize what features out of those 16 are biologically significant. And if possible, combine few molecular markers, which we can do day-to-day routine practice. And I pose some questions. Should we be site-specific in grading because the epithelial morphology is different from one side to the other? Should we have a different grading for different OPMDs, like especially OSF versus other OPMDs? And artificial intelligence and deep learning has been getting epithelial dysplasia. So that is, we are trying to answer some of these questions. The two of our PhD students are working on that, but that will take a long time for us to get some reasonable results, not for this WHO classification. Now, this is one review that we wrote recently. Now, it addressed most issues of oral epithelial dysplasia, the quantification and prognostic aspects, and the management challenges, etc. Those who are interested to read, you can read that. Thank you very much.
Thank you very much, Professor Tilakratne, for your wonderful, informative presentation. Well, there are some questions, but I think we don't have much time. I just ask you a few questions, and then we will continue with the next presentation. So one of the questions is that what do you think about the role of chronic mechanical irritation on the malignant transformation of oral potentially malignant disorders?
I think the best person to answer that question is Puyan, actually, Dr. Shakib, because I remember, gave a talk recently on that very topic. But it is a very controversial area. Some people do not agree that chronic irritation has a role to play. But most of those people who are against that also now, some of them are for it because the chronic inflammation and cancer, because that is something that people did not believe in the oral cavity. But when the enough evidence, foolproof evidence came from gastric cancer, the role of role of the bacteria and adenocarcinoma and of course multiple lymphoma. So now people do believe in most sides or the chronic inflammation and cancer. So chronic trauma can induce chronic inflammation. Why not? It may have a role, but still, as Puyan said that day, we do not have sound data. So that is one area of research, not very difficult. The younger generation of clinicians combined with pathologists can do very easy follow-up studies. Unfortunately, although this is a very common problem, we do not have good large cohort follow-up studies.
Yes, yes, of course. Hope for future collaboration and more studies on this topic. Thank you very much, Professor, for your nice presentation. It was very informative. Thank you very much.
If people have questions, they can, of course, email me. I will put my email address in the chat box.
Thank you. Thank you very much, Professor. So we will come to the next presentation. Our next lecturer is Dr. Samira Derakhshan. She is an oral and maxillofacial pathologist and assistant professor of oral and maxillofacial pathology department in Tehran University of Medical Sciences. She is also the director of the whole short course program. Thank you for Dr. Derakhshan for being here today. Her topic is Premalignant Lesions, case-based discussion. Please, Dr. Derakhshan, we are loving to hear your presentation.
Hello to everyone. Thank you, dear Dr. Mahdavi, for your introducing. Thank you, dear Professor Tilakratne, for your great presentation. It's a great honor for me being in a panel with you and also with the Professor Ranganathan. Hello to everyone. Hope you are doing well. And I'm Dr. Samira Derakhshan from Oral and Maxillofacial Pathology Department, Tehran University of Medical Sciences. First, I would like to express my appreciation to all of you to joining this scientific course, and I wish my presentation be interesting and also informative for all of you. Today, I'm here to speak about potentially premalignant oral epithelial lesions, and I prepare 4 cases in this manner. But first, I have a rapid short review about the current knowledge in this manner, and after that we have case presentation and followed by future implications. Diagnosis, identification, and management of potentially premalignant oral epithelial lesions, which have high risk to malignant transformation, lead to successful secondary prevention of oral squamous cell carcinoma, and also reduction of oral cancer morbidity and mortality. As you know, transition from normal epithelium to premalignant lesion and followed by established invasive squamous cell carcinoma is a complicated process and is related to a accumulation of genetic and also epigenetic alteration. And in addition, one of the other important issue is the management of the premalignant lesions in oral cavity remains a major challenge. Therefore, clarification and also understanding of the underlying molecular biomarkers can be very important and helpful, but this subject also is remained a major challenge, as the Professor Tila mentioned this issue very beautifully. This picture provides a synopsis of the molecular biomarkers that highlighted in the literatures, and these molecular biomarkers are associated with presence of dysplasia, carcinogenesis, and also the grade of dysplasia. On the other hand, the clinical and microscopical changes and alterations is driven by a specific molecular alteration that accumulate over the time. And I'm sure that you confirm me, it was a great win if there were molecular biomarkers that can reflect the premalignant nature of a lesion before the development of the corresponding clinical pathologic alterations. And there was another important issue that some patients with premalignant oral epithelial lesions have wide or multiple or recurrent lesion, and sometimes in some patients we have a progression to a malignancy, sometimes in another site from the initial site that identified with a premalignant lesion. Also, as you know, there are several premalignant lesions, but in my cases, I focused on the three lesions, the three first lesions, Lipoplakia, Erythroplakia, and Erythroplakine planus, because of the there are the more common in my country. And as you know, these lesions may be seen in macroscopic view with epithelial hyperplasia, hyperkeratosis, oral epithelial dysplasia, or oral squamous cell carcinoma. Very, very briefly, oral leukoplakia or the majority of the premalignant lesion have two major challenges in diagnosis and also the management of this lesion. Sometimes maybe nuclear antigen associated with the cellular proliferation, Ki-67, can be a helpful marker for diagnosis and evaluation of the degree of dysplasia. But also this marker can be helpful in evaluation of the malignant transformation risk. You see in this picture a pattern of clothes mimicking the reticular form of lichen planus. This picture has been taken by one of my students, and I like it very much by this reason. About the oral lichen planus data and the potentially premalignant nature of this lesion is very sparse. And in literatures, from 0% to up to 10% is reported. about the transformation to malignancy and also malignant transformation of oral lichen planus. Rosa reported in 2018 that oral lichen planus have an intermediate malignant potential and should be more carefully followed. And in another article, Monus reported that it is necessary about more than 5 years to malignant transformation of oral lichen planus to an established oral squamous cell carcinoma. So, as you know, that the absence of microscopic demonstration of dysplasia does not preclude a premalignant nature of a lesion, and it's a very important issue. As the Professor Tilakaratne mentioned that up to now, numerous biomarkers show promising results in evaluation of malignant transformation of the premalignant lesion like P53, MCL1, P16, MMPs, and TNF-alpha and other. But for all of these biomarkers, further studies are needed to order to establish the role of these biomarkers in clinical setting and in current medical practice. Okay, if you agree, I can start the case presentation time. And as I mentioned, I have 4 cases in this manner. All these cases are referred to our department in Tehran University of Medical Sciences, School of Dentistry. Case number 1. There was a 67-year-old female with past medical history of hypertension and known case of oral lichen planus. She presenting with left buccal mucosa, white and red plaque, and clinical impression of the surgeon was erosive lichen planus and erythroplakia and dysplasia. Incisional biopsy was done for the patient. As you see in macroscopic view, the hyperkeratotic squamous epithelium, certified squamous epithelium was evident. Hyperkeratosis is in type of orthokeratosis in most of the area, and we see the aggregation and infiltration of chronic lymphocyte in the underlying connective tissue. In some area, a rather hyperplastic changes and a rather acanthosis was evident, and the nature of the hyperkeratotic of the lesion was parakeratinized in some area. And also we have faced with infiltration, diffuse infiltration of lymphocytes in superficially areas of connective tissue. In some areas, as you see in this picture, rather band-like infiltration of lymphocyte was evident. As I mentioned, the case was the known case of oral lichen planus. But in some other areas, we face to an disappearing of retroridges and also loss of maturation and some hyperchromatism of basal cell layers. And also in some other areas, we faces to hyperchromatism and loss of maturation of epithelial layer in basal and parabasal layer. Also, we have still aggregation of chronic lymphocyte in connective tissue. As you see in this picture, some architectural and some also cellular changes are seen spatially in basal and parabasal layer, and it's a different subject between the pathologic, but hyperchromatism and also loss of maturation in this layer are evident. Also, in some another areas, we face to rather bulbous rhetoriges, like here, the board-based rhetoriges, and maybe in some area, the initiation from the decretion of the cohesion between the cells in the area of rhetoriges are also evident. Based on these features, the mild to moderate epithelial dysplasia with superficial chronic inflammatory cells infiltration reported for the patient, and comment the pathologies ordered to the surgeon, clinical pathology correlation, and also close follow-up is necessary for the patient. The patient undergone to cryotherapy, and after 10 months later, refer for an ulcerative red lesion in the same area. The area was left buccal mucosa. Because of the size of the lesion, incisional biopsy was done, and we face with this picture. Unfortunately, in the same area, there were a lot of nest and island of dysplastic epithelial cells invading the connective tissue in numerous nest and islands, and diffuse and scattered atypical mitotic features was evident among the tumoral nest, and infiltration of the severe chronic inflammatory cells, prominent with plasma cells and also lymphocyte was evident among the tumoral cells. Unfortunately, we face two individual tumoral cells and also single cells between the connective tissue. And also regional muscular bundles are invaded by tumoral cells. You see numerous tumoral nests and individual cells, single cells among the connective tissue, and infiltration of chronic inflammatory cells between the tumoral nest. For the cases, squamous cell carcinoma moderately to poorly differentiated was reported. There was any perineural and lymphovascular invasion in the biopsies samples, and also mentioned that regional muscular bundles are invaded by tumoral cells. Please close carefully follow-up of the patient is very recommended and highly suggested for all the premalignant oral epithelial lesion. In these cases, maybe 10 months was very late for the follow-up of the patient. In the case number 2, the 50-year-old male with no significant past medical history refer for an ulcerative gingival hyperplasia in area of maxillary attached gingiva in area of incisor teeth for 3 months. Clinical differential diagnosis of the patient and of the surgeon for the patient was hygienic granuloma, dysplasia, and also routing of the squamous cell carcinoma. Because of the small size of the lesion, excisional biopsy was done for the patient, and we face to these microscopic features. As you know, in this area, epithelial, papillary epithelial hyperplasia, and rather verrucous in some area. Most of them was papillary. Papillary epithelial hyperplasia was evident, and also the significant infiltration of lymphocytes among the elongated rhetoriges was evident. As you see in high power field, The hyperplastic epithelium is masked by infiltration of chronic inflammatory cells, and severe exocytosis also was evident. There is no architectural or cellular changes, but only some individual keratinization, premature individual keratinization was evident among the epithelial cells. And as you see in this area, another architectural changes was evident, keratin pearl formations in area of the rhetoriges. And as you see in these pictures, the rhetoriges are very elongated and interlocking in many areas, and also infiltration of chronic lymphocyte, chronic inflammatory cells are evident between the epithelial hyperplasia, and also the papillary growth of the epithelium is evident. Based on these pictures, the diagnosis of epithelial hyperplasia with verrucous surface was reported. Also, this report has been done by two of my colleagues, and if I find out these cases, epithelial hyperplasia with papillary surface, I prefer to sign out by this manner. Papillary epithelial hyperplasia, in my mind, is a better diagnosis for this lesion versus verrucous surface. But the lesion, less than 2 months recurrence, and you face with these pictures. Numerous island and nest of dysplastic epithelial cells, numerous keratin pearl formation, and also premature keratinization or dyskeratosis, individual keratinization, and the nest is invaded in the connective tissue. Also, we still have a severe infiltration of chronic inflammatory cells, but the nest of epithelial cells and the sheets of dysplastic epithelial cells into a connective tissue was evident in the depths of the lesion. In the deepest area, we faced a keratin pearl formation and sheets of dysplastic cells. And in the face of the epithelium, there was only thin and ulcerated epithelium. And you see this area, sheets of epithelial cell with keratin pearl formation, keratin pearls, numerous keratin pearls in the deepest area of the specimen. By these pictures, a squamous cell carcinoma, well differentiated, was reported for the patient, and mentioned that full thickness of the specimen, at least 2 millimeters, is involved by tumor. But based on the clinical feature of the patient, the surgeon decided to consult our diagnosis, and the second opinion of our reported was atypical papillomatous squamous cell proliferation and severe inflammation, suspicious for well-differentiated squamous cell carcinoma versus inflammatory pseudoepitheliomatous hyperplasia, and mentioned that the biopsy sample is very small and fragmented and also severely inflamed, and definitive diagnosis maybe could not be possible. But the surgeon decided to consult this report for the third time, and the third opinion of our reported was from another hospital pathology lab, was the squamous cell carcinoma, well differentiated, and mentioned that tumoral cells are present at the deep and lateral margin of the biopsy specimen. After 3 opinion of the microscopic slide, This view is the clinical view of the patient after recurrence and after the excision of the lesion for 2 times. And in high power field, you can see a rather red plaque in the attached gingiva area of the anterior teeth. And in the only in the anterior area, the lesion has a papillary surface, and the healing was not done after 2 months. Fortunately, on CBCT sections of the patient, bony involvement was not seen, and based on the surgeon impression, it was the reason of the early diagnosis of the patient and early staging from the lesion, and unfortunately we don't see any bony involvement in the area of the lesion. Segmental maxillectomy for the patient was done. The regional and involved tooth were extracted, and you see the excised lesion. And final report was remnant of a squamous cell carcinoma, and bony involvement was not seen in subserial sections of maxilla jaw. For these cases, it is an important point that early diagnosis of the patient can be improve the survival of the patient and also can save the patient. In case number 3, there was a 45-year-old female with multiple white plaque, and the lesion was painful. The past medical history of the patient was not significant. In microscopic evaluation of the several lesions in floor of the mouth, we face to an thin atrophic epithelial, as you see in these pictures. Only there was one architectural changes in this site in floor of the mouth of the patient, and it was basal cell hyperplasia, rather in some areas, not all of the specimen. In some areas there was a basal cell hyperplasia, as you see in this slide. But there were not significant architectural or cellular changes in floor of the mouth, fortunately. And in some areas, maybe loss of maturation and loss of stratification of the epithelial cells, especially in basal cell layer, and also basal cell hyperplasia was evident in this area. In mandibular ridge, there was epithelial hyperplastic area and also hyperkeratotic surface of the epithelium, as you see in this picture. As you see in this area, parakeratotic, hyperparakeratotic epithelial, and also it seems that the architectural or cellular changes is very minimal. But also there was some area with hyperchromatism of the basal cell layer, as you see this area, hyperchromatism, and mild pleomorphism of the cells, especially in basal layer, is evident here. And because of the artifactual changes in this slide, the loss of cohesion is not possible to evaluate in this slide. And also there was hyperchromatism and loss of stratification or maturation in some area else, as you see in this area, hyperchromatism. and maybe decrease of the cell cohesion was evident in some area. Another architectural changes was Pvl formation, as you see, and also premature individual cell keratinization. The tongue sample, unfortunately, was sent to another lab, and after the consultation, we see the slide, and only in tongue area, epithelial hyperplasia was evident, and without any evidence of dysplastic changes. As you see, tongue epithelium, there was rather hyperplastic changes maybe, and the most area was here that epithelium was hyperplastic without any architectural or cellular changes. For the lesion of floor of the mouth, mild to moderate epithelial hyperplasia based on pleomorphism and hyperchromatism of the basal cell layer and basal cell hyperplasia was reported, and for mandibular ridge mucosal lesion, moderate to severe epithelial dysplasia, but severe was only in some focus area, but moderate be more than, and with foci of prominent cellular atypia was reported for the patient. After 8 months, the patient referred to for the ulcerative lesion in a tongue area. The lesion has indurated border, and the clinical impression of the surgeon was ruling out squamous cell carcinoma. In this time, we request the patient and the surgeon to back to the previous lab to consult and rechecking the initial slide of the tongue lesion. And we saw the initial lesion only was epithelial hyperplasia, as you see in the previous slide. Initial biopsy was done from was checked and also consulted with us. The initial diagnosis of the lesion of the tongue after the second initial biopsy was squamous cell carcinoma. A squamous cell carcinoma from tongue lesion from a recurrent lesion of epithelial hyperplasia was consulted with our lab, and we saw the both slide. You see in this slide the slide of another lab that reported a squamous cell carcinoma for a tongue lesion. As you see, first the normal epithelium, and maybe some changes in this area, and some suspicious area in the high power field. You see epithelial hyperplasia and followed by severe epithelially dysplastic epithelium changes, and also this suspicious area. In high power field, you see sheets of dysplastic invasive squamous cell epithelial cell that invaded the connective tissue, which infiltrate by severely infiltration of lymphocyte chronic inflammatory cells between them, and also focus area of keratin pearl formation was evident. High power field, you see some maybe suspicious for mitotic figures. The lesion was very poorly differentiated, and there was some basal cell also evident among the tumoral cells. By this area, be reported and confirm the diagnosis of poorly differentiated squamous cell carcinoma that the initial pathologic lab reported for poorly differentiated squamous cell carcinoma non-keratinizing, and also we confirm its diagnosis and also poorly differentiated squamous cell carcinoma was reported for the patient. In these cases, be aware about in multiple lesion performing biopsy is mandatory for each lesion separately. And also we should be aware about that one lesion cannot be representative of the other lesions, even their clinical feature was very similar to each other. And also as I mentioned in the previous cases, close follow-up of the patient is very suggested. And also make sure about the selection of the best. Here the best is the worst area for biopsy, for doing the biopsy. Because maybe the initial biopsy of this lesion that reported epithelial hyperplasia, and we recheck the slide and confirm the epithelial hyperplasia, maybe has been done from a bad area, and that area was not representative of the lesion, and squamous cell carcinoma may be diagnosis in the sooner time. In the last case, the case number 4, a 55-year-old male, a known case of hyperthyroidism with a large white verrucous lesion. The lesion was located in the buccal mucosa from retromolar area to commissure, and also the lesion has another lesion in the papillomatous lesion in hard palate area, and he reported that this verrucous surface lesion is from more than 1 year maybe, and the initial incisional biopsy from the verrucous lesion in buccal mucosa was done about 6 months ago. And after that, the patient ignored and postponed the lesion, and in the present time, because of the increasing size of the lesion, the patient come back to his doctor, and also for management of the lesion after 6 months. You see here initial biopsy from the patient in retromolar area and lip angle, papillomatous epithelial hyperplasia without dysplasia. This report is not blind to our center. Papillomatous epithelial hyperplasia without dysplasia and with severe myelial fungal, and also in lip angle, keratotic papillomatous epithelial hyperplasia without dysplasia. And in palatal area, papillomatous also, again, epithelial hyperplasia without dysplasia. And the incisional biopsy was checked and examined for high risk and also low risk HPV infection, and the result was negative. Now, after 6 months and increasing the size of the lesion and leading to some problem for the patient to opening the mouth, he comes back. You see here verrucous surface of the lesion in buccal mucosa and commissure area. The patient was not able to open his mouth more than this. And in this time, the second initial biopsy was done for the patient. You see here the lesion in hard palate area, and as you see in these pictures, only epithelial hyperplasia with rather papillary surface, hyperplastic retro-ridges and interlocking in some areas was evident. There were not any architectural and cellular changes in palatal lesion of the patient. As you see in this slide, the only hyperplastic epithelium was evident. But in the second biopsy for the retromolar area and buccal mucosa area, we saw the hyperplastic epithelium in papillomatous and also verrucous pattern. As you see in this slide, the epithelium is very hyperplastic. There was abundant area of keratin formation, as you see in this area, and papillary projection. Numerous papillary projection was evident. In this area, you see prominent area of hyperkeratotic epithelium. And also we saw some maybe keratin horn in this specimen, as you see in this slide. There was a real verrucous epithelial hyperplasia. And also you see here verrucous surface of epithelium with prominent keratin formation and sheets of superficially keratinization. In evaluation of the epithelium, you see in some area the superficial epithelium was separated from the connective tissue. And also in examination of the cellular changes, there was not significant cellular changes or cellular dysplastic changes, or only there was pushing borders in some area. As you see here, the proliferation of the epithelium downward to the connective underlying connective tissue has the pattern of pushing border in many areas, and also the surface was very verrucous pattern, has very verrucous pattern, and without any dysplastic changes or architectural and cellular changes. And as you see in the high power field, maybe a pushing border of the epithelium was evident. And you see there is not cellular changes like hyperchromatism or pleomorphism, maybe decrease of epithelial cohesion, maybe see, but another cellular changes was not seen and was not evident in subserial sections. For this patient, verrucous epithelial hyperplasia consistent with verrucous carcinoma was reported. And for hard palate, as you see in the first three, I think three slides of this patient, papillomatous epithelial hyperplasia was reported. And also we mentioned for the surgeon that, dear colleagues, some verrucous carcinomas show focal initial squamous cell carcinoma, and inability to identify this area is one of the reasons of treatment failure. After this comment and after consultation with the surgeon decided to treat a patient like an well-differentiated squamous cell carcinoma. and whole lesion excision was done, and also selective neck dissection because of the duration of the lesion and because of the permanent, it was a permanent lesion, and also because of the features that clinical features that the surgeon was in this manner, that this lesion maybe has areas of undiagnosed the squamous cell carcinoma, and decided to treat the patient in this manner. And as you see in the final report of the patient, and it is not blind to our center, Verrucous squamous cell carcinoma was reported for the patient, and in selective neck dissection, 12 dissected lymph node was seen, and fortunately, all of this lymph node was free from tumor. But the surgeon decided to treat this patient like as I mentioned, well-differentiated squamous cell carcinoma. Because of this region, and because of this reason, you see the final report was a squamous cell carcinoma. The patient is alive and with no significant yet. It's very important based on these cases, we should be aware and careful about several clinical pathologic features that may be associated with increased risk of malignant transformation. In a beautiful review, Ranganathan reported that and listed there may be some risk that may be associated with increasing risk of malignant transformation, like female gender, like long duration of the lesion, like non-smokers patient, and also size greater than 2 centimeters, non-homogeneous type of the lesion, and also the area of the lesion in especially in tongue and floor of the mouth. This list that indicate the risk may be increasing in this manner, and we should be careful about the treatment of the premalignant oral epithelial lesion, that it's suggested that optimal management approaches like closer monitoring for the patient, and also more aggressive therapeutic intervention for improving the prognosis of the patient, and also to saving the patient is highly recommended. And also there is another important point, that there is a general agreement and consensus about that the current approaches in and systems in grading of epithelial dysplasia is not useful for predicting the patient's outcome. And therefore, because of this lesion, definitive treatment of all epithelial dysplastic lesion, even mild dysplasia, suggested to be definitive treatment. And I think that some of you think about that this approach may be an over treatment of the patient. Maybe some of you think about that, but the literatures and studies are agree and accept this manner, that the definitive diagnosis for all premalignant oral epithelial lesion is very acceptable and suggested, and very suggested. And also the wait and watch approach that the Professor Tilakaratne also mentioned, that may be useful and should be used only for mild epithelial dysplasia, to prevention to and establish oral squamous carcinoma, and to save the patient, and also to improving the outcome of the patient. And finally, this beautiful picture of our faculty, School of Dentistry in Tehran University of Medical Sciences in night sky, dedicate to all of you. And it's my pleasure that I'm a small member of this family. And you find me by this email, and I'm here to tell and see your comments and answer your questions. Thank you so much for your attention and time. Thank you.
Thank you very much, Dr. Darakhshan, for your informative, nice introduction presentation. It was very interesting cases. Thank you for this presentation. So there are some questions which I would like to share with you and Professor Tila Karatne. And one of the questions is, which is also my question, that some people, when you have a kind of chronic irritation or a severe inflammation, you will see some changes in the in the overlying oral epithelium, like disorganization of the structure of the epithelium or presence of some atypical features. Some people consider this as a reactive atypia. So my question is, when I'm examining the lesion under the light microscope, I see some features of dysplasia and inflammation. How can I know that it is a true dysplasia and the inflammation is present secondary to the presence of dysplasia, or it is an inflammatory lesion and the dysplasia is reactive to the presence of inflammation?
Okay. Thank you, Dr. Martani. I think based on our cases in our lab, when we face to a patient with has a clear history of irritation in oral cavity, and he reported that for us, and we see the evidence of this traumatic lesion in oral cavity. The first diagnosis is the a lesion or a reactive atypia associated with the irritation and with a chronic trauma that we can see in a clinical setting or a patient reported for us. And after rule outing the chronic irritation and the traumatic nature of the lesion, we can think about the other lesion and other real dysplastic changes of the lesion. And also I comment that the very close follow-up of the lesion is very important in this manner, because all inflammatory and all reactive lesion in oral cavity, as you know, after 2 weeks, regression or maybe decrease in size. If we solve the irritation of the lesion and clinical traumatic origin for the lesion, if we solve this problem, we can see regression or even the decrease in size for the lesion. And close follow-up is very important and can helpful for to distinguish between this lesion. I'm very happy to hear from Professor Tila Karatne. Can you guide me?
Two things. One is clinical, one is histopathological. Now, as I told you, the lesions which occur, keratotic lesions which occur due to trauma, there are characteristic features. If you look at the surface of the epithelium, there is shredded, we call shredded keratin, the disturbed keratin layer. And also, if the trauma is severe, you will see the surface epithelial cells undergoing varying degrees of degeneration, starting from cloud saline to hydrophobic degeneration to vacuolar degeneration. Right, so those changes you can see on the surface. Now, one of the characteristic features of traumatic lesions or frictional keratosis, if you like, So you don't have inflammation there. It's a characteristic feature not to have inflammatory cell infiltrate underneath, right? But if you are talking about regenerative atypia, that is most of the time in relation to edge of an ulcer or healing ulcer. But one of the features that you can recognize that is underlying corium, subjacent corium is not normal. It is granulation tissue. So you will see some granulation tissue, some neutrophils in addition to lymphocytes. That is pathology. The clinical, now once, if it is a traumatic lesion, once you recognize the traumatic cause, once you remove it, within 2 weeks, 10 days to 2 weeks, you should see signs of healing of the lesion. If it is not, it is a sinister lesion. Otherwise, it's traumatic. I think I answered your question.
Yes, yes, completely. Thank you very much. Thank you very much, Professor Tilakaratne. Thank you very much, Professor Darshan, for your nice presentation. So, so we're just on time for the next lecture. The next lecture is, so I'm honored to introduce the third lecturer, Professor Ranganathan. He is the professor and head of Department of Oral and Maxillofacial Pathology, Rangas Dental College, Chennai. He is currently president of Asian Society of Oral and Maxillofacial Pathology and also secretary for International Association for Oral Pathology. He is also the chairman of Fellowship Committee in Indian Association of Oral and Maxillofacial Pathology. The topic of Professor Ranganathan's presentation is head and neck cancers, an overview. Thank you, Professor Ranganathan, for accepting our invitation. I love to hear your presentation. Please.
Thank you very much for the kind introduction. Let me share my screen here quickly. How do I do that? Can you see my screen? Am I audible? Is the screen visible? Can you hear me?
Yes, yes, I can hear you clearly, Professor, and also can see your slide too.
Awesome. Thank you very much. Thank you very much for the kind introduction. It's a pleasure to be here again at this webinar hosted by the Tehran University of Medical Sciences. And let me thank Dr. Payan for his invitation and making it possible to share some time with you all this evening. Thank you very much. I think both the speakers who went ahead of me sort of indicated that the important event is cancer. The idea of learning about oral potentially malignant disorders, assessing it, evaluating it, is to make sure that it doesn't progress to cancer, isn't it? And head and neck cancer is a major problem. These are the issues we face when we talk about head and neck cancer. Cancer is one of the leading causes of death in the world, leaving aside the current pandemic situation of COVID. It is a major health problem because head and neck cancer is probably one of the top 10 cancers globally. And if you look at countries like India, 1 out of 3 cancer is oral cancer. This is a major public health problem. And this is because of a combination of factors. You have extensive habits, high-risk habits, a problem with accessibility to early diagnosis and early management of these lesions, which make it a condition with significant morbidity and mortality, and accessibility to treatment, which is once again a big problem depending upon which part of the world you are. So I'll talk a little bit about the impact of the extensive nature of this problem, so that those of you who are dealing in a hospital setting with the public health issues are aware exactly what the quantum of problem is. Diagnosis, clinical diagnosis, and histopathological diagnosis of early cancer can be a little bit tricky. And I think both the previous speakers, Professor Tilak and Dr. Samira Darakshan, made this point very clear. In a well-established cancer, histological diagnosis is not a problem. It's a problem in the early stage. Probably you have to be careful about the variants of squamous cell carcinoma, which you can trip on. I'll talk a little bit about that. What is important given the magnitude of the problem is, how do you stratify these patients for treatment and prognosis? I'll touch upon that, what the recent developments are. So based on the issues that you're likely to face with oral cancer, this is how my presentation is going to be structured. I'll touch upon epidemiology, which, like I mentioned, is a very important public health issue if you're going to be tackling cancer. We'll talk about oral cancer and oropharyngeal cancer. And under these, I'll talk about the risk factors. And knowing risk factors is very important, not only as to prevent these conditions, not only to inform patients, but it's important to realize that depending upon the habit, the molecular signature of the tumor can change. So knowing the etiology is not only important to prevent these habits and educate patients, but it's important to realize that if you have to tailor treatment to these patients, different etiological factors have different molecular pathways which are triggered, making it a very, very heterogeneous and a very complex problem. I'll talk a little bit about the types of squamous cell carcinoma you're likely to face in the oral cavity. I'll touch upon the histopathology and the variants which you need to know about. And I'll delve a little bit on the recent updates on staging. That is the TNM staging, which is based upon the anatomical extent of the tumor. And I'll tell you what is the premise, what is the rationale behind which this TNM staging works. For the most part, I'll stick myself to oral cancer. I'll very briefly touch upon oropharyngeal cancer when we talk about the risk factor and HPV. But the remaining part of my presentation is going to focus predominantly on oral cancer. Okay, a little bit of statistics initially. If you look at cancer as a whole, globally in 2020, we had about 19.3 million new cases and 10 million cancer deaths. That's a huge number. But what is even more alarming is if you look at the projection for 2040, you expect a 47% increase or jump if you don't intervene, if steps are not taken to reduce this, which means you'd have about 28.4 million people globally having some type of cancer. And mind you, this varies depending upon the HDI, the index of development in different countries. And if you look at it uniformly, be it developed, a very high HDI index specified by the UN, or a medium, or a low high index, the Human Developmental Index. All these countries, all our countries are going to see an increase in cancer. For example, India would fall under a medium HDI. There's going to be a 64% projected increase. Malaysia probably falls under a high HDI or very high HDI. And I think Iran falls under high HDI. So cancer is a major problem. And if you look at the WHO estimates in 2019, cancer is the first or second leading cause of death before the age of 70 years in 112 countries out of 183 countries. And it's probably the second or third leading cause of death in about 23 countries. And like I said, it depends upon the economic status of the country, the type of cancer which is the most prevalent, and depends upon the Human Developmental Index in these countries. Okay, it's important to realize that the cancer of the head and neck is not a single entity. You have probably 3 subtypes: oral cancer, which I shall focus on predominantly today; oropharyngeal cancer, which is this area which you're looking at here, right in the posterior aspect. I'll talk about that in a minute. And cancer of the lip. And cancer of the lip by itself is divided into two. You have what is called the wet zone and the dry zone, divided by the vermilion border. So the wet zone is what falls in the preview of the oral cavity or oral mucosa, whereas the dry zone, the outer to the vermilion line, is a cutaneous type of cancer and does not come under the classification of oral cancer. So you have oral cavity, lips, and oropharynx. Okay, now these are the boundaries we are talking about. When you talk about oral cancer, it could be any of these sites, any of the soft tissues. It could be the buccal cavity proper or the vestibule. Now, when you talk about the oropharynx, it is posterior to the tongue. So it involves the soft palate, the uvula, and the tonsils. And that's the oropharynx. And usually the nasopharynx and the hypopharynx are not taken into consideration. If you need the anatomical boundaries of these regions, see, oral cancer is restricted to the lip, the tongue, the gum, the floor of the mouth, palate, and the vestibule and the remaining areas of the mouth. And we say oropharyngeal cancer, we mean the base of the tongue, the soft palate, the uvula, the palatine tonsils, the lateral and the posterior wall of the pharynx. The nasopharynx and hypopharynx are usually excluded from this classification. So it's important to remember that when you read different articles and different manuscripts, to make sure that a lot of times what happens is when they say oral cancer or head and neck cancer, there's a tendency to club oral cancer along with oropharyngeal cancer. And that can be a problem because these two are entirely different as far as the etiology is concerned and as far as the prognosis is concerned. A little bit about statistics of oral and oropharyngeal cancer. In 2018, about 354,864 cases were diagnosed with oral cancer globally. And if you look at oropharyngeal cancer, it's around 93,000. Combined, they are the 8th leading cause of cancer worldwide. They account for 2.5% of all cancers globally. And 90% of these cancers, particularly in the oral region, tend to be squamous cell carcinomas. Okay, this is important to understand that there is a huge variation in the geographical distribution of oral cancer. 2/3 occur in low-income countries or where the HDI or the Human Developmental Index is low. Half of this is in South Asia. And the geographical variations involve different age groups, different genders associated with different habits in different parts of the world. But what is interesting is, and we in India also noticed this, there is an increase in the cases reported from tongue, cancer of the tongue. And very interestingly and very alarmingly, these cases occur in patients without habits and in the younger age group. So we are starting to see cancer in patients who are in the 3rd and the 4th decade without any habits, which brings up the interesting possibility of chronic trauma and irritation and chronic inflammation, which we just discussed a few minutes back. Human papillomavirus or the high-risk human papillomavirus is not a significant factor as far as oral cancer is concerned. It plays a significant role in oropharyngeal cancer, but not a significant role in oral cancer per se. Like I said, we are starting to see these cancers in the younger age group, and that is really alarming situation. A little bit about India, we see about close to 100,000 cases per year. It's one of the most common cancers, and 1 out of 3 cancer reported in India of all the cancer is oral cancer. And that's a huge number. This was the statistics which I could find, and Dr. Poyan can correct me when he follows me for this presentation. It's among the top 10 cancer in several provinces in Iran, and around 450 new cases are reported per year. And the age standardized mortality ratio is around 0.7 in men and 0.6 in women per 100,000. So it is a problem in that part of the world too. You need to know about risk factors. Like I mentioned earlier, it's important from a public health perspective. It's important if you're going to take preventive measures and educate the public regarding what to avoid and what not to avoid. And this can be a little bit tricky with some habits. I'm going to tell you that in a few minutes. And it's also necessary to know the etiology because the molecular signature of the cancer differs depending upon the causative factor. These are the known factors for head and neck cancer, the established ones: tobacco, alcohol, betel quid. I think Professor Tilak made a big point of this. This is associated with areca nut chewing. And the nut itself, and he showed excellent pictures, and I shall show you a few pictures, is taken alone or in different forms in combination with tobacco and betel leaves. What is interesting is it's no longer restricted to India or Southeast Asian countries, thanks to the expatriate population in different parts of the world. You can get areca nut and betel quid pretty much in any part of the world except where it is banned. So you see the Indian diaspora or the Southeast Asian population in different countries taking on this habit, and it spills over to the people who are indigenous to that particular location. So the traveling and the fact that the international boundaries are becoming a little bit sort of big for people transporting for work, people migrating, immigrating and emigrating, these habits are no longer restricted to one geographical location, but are carried on to different countries. And this can be a problem. And of course, high-risk human papillomavirus. I'm sure you're aware that there are more than 100 subtypes of human papillomavirus. 40 of them are sexually transmitted. 2 which are high risk, particularly in the oropharyngeal carcinoma, are the high-risk HPV 16 and 18. And these are distinctly and specifically associated with oropharyngeal cancer, making it a separate classification by itself. Just to give you an idea of the nature of the problem, this is the adult tobacco survey from India. It's a very, very busy slide, but I like to put this so that you can understand the quantum of the problem. About 99.5 million people, adults, smoke tobacco. When you look at the percentage, it seems very small, 10%, but if you consider the fact that India has got 1 billion people, 10% is a huge number. And about 21.4% or around close to about 200 million of adults use smokeless tobacco. Now that is a major problem in India. But the interesting thing is, in very many cases, smokeless tobacco is associated with verrucous carcinoma, which has got a better prognosis than squamous cell carcinoma. However, like it was discussed in the case presentation a few minutes back, verrucous carcinoma can have foci of oral squamous cell carcinoma, and then you have to treat it like a squamous cell carcinoma. And this is a very important point you need to consider when you handle these cases clinically. And combined, if you look at any form of tobacco, it's close to 29% of the 1 billion population, which is around 267 million people, use tobacco. And given the high association of tobacco with cancer, you can see that this is an explosive problem. This is a major problem in the Indian subcontinent. This is, you have the references right there at the bottom. This is a very, very interesting compilation of articles. If you're working with oral cancer and you want to look at the different risk ratios and odds ratios associated with different habits, it's important to see that there are different ways in which tobacco can be used. You have smoking, you have cigar, you have cigarettes, you have pipe, you have BD smoking, which is once again rampant in the Indian subcontinent, chewing tobacco, which is prevalent in the United States too, and of course chewing tobacco in India. And if you look at the OR, it ranges from about 2.5 to as high as 5.67 or 5.7. So a huge risk associated with using tobacco in any form whatsoever. Because as a public health issue, we have a lot of times when we say patients who stop tobacco use, smoking, they'll take up chewing tobacco. Or when we say no tobacco, they'll take up areca nut. And areca nut is a major problem in this part of the world, and I'll tell you why in a minute. Alcohol. Many years back, at least 15, 20 years back, I used to be taught that alcohol per se does not cause oral cancer because most of the alcoholics or people who consume alcohol use tobacco and have other habits. They have a poor nutrition. They do not take a proper diet. A combination of these factors makes taking alcohol a predisposing factor. But a lot of studies have proven otherwise. It is definitely a carcinogen for oral cancer, as shown in the IARC monograph. You have the reference there. The frequency and duration of alcohol intake is by itself an increased risk factor for oral cancer. And there is definitely a dose-response relationship for the risk of both oral and oropharyngeal cancer in both the sexes, male and female, as far as oral cancer is concerned. So alcohol per se itself is a carcinogen and can predispose to development of cancer. This is a very interesting substance, a betel quid. I'll not talk much about it because Professor Tilak has covered it extensively. It's a group 1 carcinogen. And a lot of times it is used in conjunction with tobacco, making it even more of a problem. And sometimes in studies, it's very difficult to separate them and study them separately because very many a times, areca nut is sort of mixed with tobacco and a lot of other chemicals like silica lime. This is an interesting meta-analysis if you're interested in working in this field. And it shows the relative risk in the meta-analysis in different parts of the world. And you have one for India. This is betel quid without tobacco. This is betel quid with tobacco. And in Taiwan, betel quid without tobacco. Look at the relative risk. From 2.56 to 7.74 if you club it with tobacco, and 10.98 or close to 11 in Taiwan. And this is once again got to do with the type of areca nut which is used, the combination with which it is used, and the duration and the frequency of use of these areca nut along with betel leaves, which is called the betel quid. I think Professor Tilak showed a similar picture, and this is just to tell you that each of these release different amount of the substance which is responsible for oral submucous fibrosis, which is a potentially malignant disease associated with oral cancer. And I was, I think I did see a question crop up in the chat box that said that oral submucous fibrosis happens in the connective tissue. And why do you see dysplasia in the superficial epithelium? Well, this is because of the crosstalk between the epithelium and the connective tissue. Plus, the other factors include ischemia of the underlying connective tissue, more exposure to ROS or reactive oxygen species of the epithelium. So it's a very, very close orchestrated event between the epithelium and the connective tissue. Though the initial event is restricted to the connective tissue, the epithelium is also severely affected. Another point to note is, depending upon the type of areca nut used, the active ingredient, which is arecoline, which is an alkaloid, which is responsible for submucous fibrosis, and aricadine, and there's some, to a lesser extent, guacoline and guacadine. These cause the alterations which you see in oral submucous fibrosis, and subsequently leads to epithelial changes, which lead to oral cancer. And these are very, very difficult to treat because the patient's mouth opening is restricted, and they are a nightmare for the surgical oncologist. As far as treatment is concerned, assessment of the extent of the lesion is concerned. Though there are reports which say that, especially from Tata Memorial Institute in India, which is one of the leading oncology centers, that patients with submucous fibrosis who develop oral cancer tend to have a better prognosis or tend to respond better to treatment than those associated with tobacco. I just put this quickly because to tell you how difficult it is to stop some of these habits depending upon the regional beliefs. For example, this is a place of worship in India where the deity is actually decorated with areca nut. And actually this was taken from one of the articles way back called Areca Nut Economy at the Crossroads. And this is to drive home the point that areca nut is also a cash crop and it contributes significantly to the economy. So this combination of factors, for example, the fact that a lot of people are involved in areca nut farming and it is associated with religious practices, and when people sort of join together in social occasions, And the fact that very many are not aware that areca nut is as much a carcinogen as tobacco makes it very, very difficult to control. And this habit of areca nut and its different forms being used, I've seen it being used in almost most of the countries that I have visited by both the Indian diaspora or the Southeast Asian population there and the local people. They will pick up their habit from the Indians living there. Quickly about oropharyngeal cancer. The high-income countries are seeing a steady increase in oropharyngeal cancer. Oral cancer is coming down. Oropharyngeal cancer is going up. This is especially true in younger people in North America and Northern Europe, where 70% of the oropharyngeal cancers are because of high-risk human papillomavirus. And this is a graph derived from the SEER data from 1984 to 2004. You can see that the incidence of oropharyngeal cancer is going up and the incidence of head and neck cancer in these countries are coming down. That is, there's a 225% increase in HPV positive squamous cell carcinoma of the oropharyngeal region versus a 50% decrease in HPV negative squamous cell carcinoma in these regions. So human papillomavirus is a very important factor, particularly in the oropharyngeal region. So quickly, tobacco and alcohol are a problem in oropharyngeal region too. And the human papillomavirus, particularly the high-risk type 16 and 18 are responsible. 90% of it is HPV 16. So there has been a 70% increase, more in younger patients. And these tumors have distinct tumor biology. They have a separate clinical staging reflecting the biology and the behavior of these lesions. The good thing is they are highly sensitive to treatment, respond very well, and have a good prognosis. This is just a comparative chart between oral cavity oropharynx, which is P16 negative, which is a surrogate marker for HPV infection, and oropharynx, which is P16 positive. So we are starting to see an upsurge, especially in developed countries with the high HDI, Human Developmental Index, that it's associated with HPV high risk rather than tobacco, whereas the oral cavity cancers are more associated with tobacco, areca nut, or alcohol, and a combination of these. And once again, this is a reflection of the economic position of the particular country. Quickly, before we go into oral cancer per se, the HPV and head and neck cancer, as far as oropharyngeal is concerned, these two articles are very interesting. And if you're working in this area, you may want to take a look at them if you have not already done that. Now, this reviewed about 2,207 peer-reviewed articles, 492 studies, and they have about 14 guideline statements for HPV and oropharyngeal cancer. I'm just going to tell you 4 important ones, which are good for a take-home message if you're working in this area. High-risk HPV testing is mandatory on all newly diagnosed oropharyngeal carcinomas. This is very important. So if you have an oropharyngeal carcinoma for the first time, you have to test for HPV. High-risk HPV testing is not to be routinely recommended on non-squamous carcinomas of the oropharynx and non-pharyngeal carcinomas of the head and neck. So if they are non-squamous carcinomas, you don't need to do HPV testing. That's the recommendation currently. P16 overexpression is strongly associated with transcriptionally active high-risk HPV and oropharyngeal cancer, and P16 can be used as a surrogate marker. And for high-risk HPV positive P16 cases, tumor grade or differentiation, such as high grade, low grade, you needn't do that. It's not recommended. So if it's HPV16 positive or P16 positive, you don't need to grade the tumors like what we do for oral cancer. So those are the 4 recommendations of the 14, which are important. So you need to understand that this is a very important point. Presence of HPV in the oral cavity or the oropharynx does not necessarily mean that they're going to get cancer. They're going to get cancer. So for it to produce a lesion, for HPV to produce a lesion, it should integrate with the genome. It should be a persistent infection. And most important of all, It should evade the immune system. The immune system should be ineffective against it. So we need a combination of these three: integration, expression of a persistent infection, and ability to evade the immune system. You need all these three. So just the presence of HPV is not necessarily going to be associated with a high risk for the development of cancer. Protective HPV infection can be what is called persistent or transient. What it does is it impairs the keratinocyte differentiation. So when you look at the histopathology, you're going to see altered keratinization pattern and also altered epithelial organization or stratification. And if you look at molecular techniques, you're going to see viral DNA integration and epigenetic changes. There's going to be high level of E5, E6, and E7 expression. And there's going to be a progressive genetic aberration favoring tumor progression. If it's a transient infection, the keratinocyte differentiation is maintained. These become benign lesions like papillomas. And there is very low E6 and E7 expression. So it's very important to understand that just by doing an in situ hybridization and showing that HPV is there, doesn't necessarily equate that as a cause for oral cancer. So you need to look at the features of keratinization, which has been sort of disturbed, levels of E5, E6, E7, the amount of integration and epigenetic and associated changes. So, and immune changes which push it towards development of oropharyngeal cancer. Transient infections which do not have these features result in benign lesions like verruca and papillomas. Okay, well, that's just to give you an idea of the nature of the problem. And it's a huge problem depending upon which part of the world you live in. And I don't think any country is spared the ravages of oral and oropharyngeal carcinomas. I think each of us deal it with a different way as far as the quantum of the problem is concerned. Clinical diagnosis sometimes is very, very straightforward. If you have a lesion like this, the patient comes in, the patient opens the mouth, you can probably diagnose this lesion 1 feet away. So this is not a diagnostic challenge. But sometimes it can be a diagnostic challenge, especially when you have lesions looking like this, which start looking like verruca or condylomas. And it's exophytic, very soft, with not significant induration of the underlying mucosa. Or if the entire mucosa looks like you have multiple abscesses and necrosis. This is a problem because to take a biopsy, you need to be very, very careful because some of these changes may be just necrotic tissue. So you need to be very careful and the clinician needs to work with the pathologist, excuse me, to make sure that they get the correct appropriate biopsy. And if you do not have clinical details, which happens in very many places, you may totally miss the lesion if it's not been biopsied appropriately. So that can be a clinical challenge. And palatal lesions can look very unusual. This was an erythroplakia with necrotic debris. This is a frank oral carcinoma of the palate, where there's total expansion both palatally and buccally. So that's not a diagnostic challenge. The tongue can be tricky. If you do not do a thorough examination of the tongue, a lot of times it can be missed, and it has been missed. Now look at this patient. The patient was asymptomatic, had come for some routine dental treatment, and he just mentioned that there was some sort of a discomfort or restriction of movement on that side of the tongue. And then you looked at the lateral surface of this tongue, there was this nice exophytic sessile lesion, indurated, and has been there for months. And the patient thought that it was some sort of an ulcer and was applying something topical. And lesions can be very subtle. For example, this lesion here, lateral surface of the tongue, a higher magnification. This was treated as a traumatic ulcer for quite a long time with surface topical anesthetics. And by the time the patient presented to us, it was a squamous cell carcinoma which had invaded deep into the muscle fibers. And this is very posterior to the anterior 2/3 of the tongue. And very many times, these are attributed to, once again, what we discussed, what we have been discussing, chronic irritation or sharp teeth, or if the patient has a prosthesis, irritation associated with prosthesis. We're starting to see some of these. I have seen only one cases, but I have some of my colleagues who seem to see 1 or 2 cases of this. This patient had an extensive dental restoration, and an implant was done. Multiple treatment was done. The patient had some endodontic treatment. The lesion didn't heal. Then the patient had some gingival curettage, didn't happen. Then they put an implant, and this lesion was there, and they thought it was some reaction to the material used. The prosthesis was removed and took a biopsy, and it turned out to be a squamous cell carcinoma of the alveolar ridge. So you need to have a very, very high index of suspicion in these cases. Submucous fibrosis, diagnosing oral cancer can be very, very tricky. I'm just going to show you one slide for that. This was a case of oral submucous fibrosis. You can see a lot of pallor. It's just erythema. I think this point was made in the first lecture by Professor Tilak. This is erythroplakia. And we as a rule consider that if you see an erythroplakia, we consider it to be a squamous cell carcinoma unless it is disproved by biopsy. So clinically, we call it a squamous cell carcinoma unless you can say it's otherwise by taking a biopsy. And as the mucosa is already very fibrous to palpation, you cannot distinguish between induration because of squamous cell carcinoma and secondary to the oral submucous fibrosis because of varicanotorbital chewing. And these lesions are very, very tricky. Fortunately, this was in a very accessible position. If it was in the retromolar trigone area and the patient has limitation of opening the mouth, even assessing these tumors and diagnosing them in the early stage is going to be very, very difficult. It's a major clinical problem. This is drawn from slides from different parts of the world. And I think some of these slides are when I was a resident at the Ohio State University. All these cases are squamous cell carcinoma. This is a squamous cell carcinoma looking like a leukoplakia. This is looking like a gingival enlargement, sort of avascular pyogenic granuloma in an immunosuppressed patient. An edentulous ridge in the floor of the mouth, which looks erythroplakic. And I think we just saw a very similar case in the case presentation today, presented as a boggy gingival swelling, which turned out to be squamous cell carcinoma. So though it looks like diagnosing squamous cell carcinoma should not be a problem, diagnosing it early and catching them early is a little bit difficult. And depending upon the etiology associated with the squamous cell carcinoma, they can have varying presentations. And this is made all the more complex by the locoregional anatomy of the oral cavity, because the oral cavity has different levels of keratinization, ability to stand to trauma, and different thickness of epithelium in different parts of the oral cavity. So diagnosing some of these in the clinical context will be very difficult unless you have a very high index of suspicion. Let's move on to pathology now. I'm sure all of you dealing with oral cancer post-surgical specimen, there are different ways in which you can enter the synoptics, the data sets with core and non-core elements. You have one of the synoptics data set by the College of American Pathologists. Some people follow the Royal College of Pathologists. Then you have that by the ICCR, the International Collaboration of Cancer Reporting. And of course, you have UICC, Union for International Cancer Control, and AJCC. Of course, now the UICC and AJCC is a combined staging system. So you're going to be following that. So depending upon which system you follow, there can be subtle differences when you're logging in the details, when you're grossing in the specimen, when you're staging these patients for appropriate treatment. For example, if you look at patterns of invasion, if you look at the Royal College of Pathologists, UK, the pattern of invasion is broadly divided into two groups. You have one where there's broad cohesive sheets or strands of cells with greater than 15 cells across. And then you have narrow strands, which are non-cohesive, small groups or single cells. And you look at the AJCC classification, we have what is called the worst pattern of invasion 5, which means it's about greater than or equal to 1 millimeter from the main tumor or nearest satellite. So depending upon whichever data set you're used to recording, there may be subtle differences in how you record these cases. And when you look at oral cancer, all these factors need to be considered: the grade of the tumor extension, the specimen margins, the tumor bed, lymphovascular invasion, perineural invasion, worst pattern of invasion, regional lymph nodes, multiple tumors, and recurrent tumors. I'm going to talk only about a few of these and those which are very important as far as a beginner is concerned when you're starting out doing these cases. Grading is what we follow is the WHO system, well differentiated, moderately, and poorly differentiated. In some cases, it cannot be assessed or specified. And then you have different variants of oral cancer. You have the verrucous type, the papillary type, the carcinoma cuniculatum, the spindle cell, the basaloid, the acantholytic, and the adenosquamous. Quickly to the different grades, that's a well differentiated squamous cell carcinoma. moderately differentiated with very little keratinization, and you're looking at individual cell keratinization where the arrow is pointing. And here, these are the keratin pearls. And of course, in a poorly differentiated squamous cell carcinoma, no keratinization, significant pleomorphism, a significant anisocytosis and poikilocytosis. You have different grading systems over a period of time. All of these take into consideration the pattern of invasion of the cells into the underlying connective tissue, the nuclear pleomorphism, the differentiation and the organization of keratinization, mitotic activity, and some of them include lymphocytic or tissue response. And you had, in 2005, Martinet, Gimeno, and Brandwein Jenslerby suggest what is called the histological risk assessment, where in addition to the other features, they included perineural invasion, lymphovascular invasion, and tumor thickness. Tumor budding, particularly in tongue, carries a very, very important predictive value, and this is associated with poor prognosis. The type of invasion is very important. You can have 4 possible types. One, you can have pushing border at the same level. You can have infiltrating cords and islands continuous with the tumor. You can have infiltrating cords and islands separated from the tumor mass. And then you can have small individual single cells infiltrating. So that's how type 1 looks like. That's a cartoon of a type 1. Type 2, larger islands. Type 3, smaller but still significant cells clustered together. And type 4, individual cells sort of infiltrating into the underlying connective tissue, and they can almost start looking like epithelioid macrophages. Histologically, that's how type 1 would look like, a pushing margin. Type 2, it's starting to separate out from the above connective tissue and starting to go into deeper, but still you have large islands and cords. Type 3, the islands and cords are becoming smaller and more deeper infiltration. And type 4, you have these individual cells sort of infiltrating deeply. And I think we saw an example of that case in the case presentation in the last hour. You can narrow down these 4 types into either cohesive, non-cohesive, or dispersed pattern, which makes things a little bit more easier. The first 2 patterns become cohesive at large islands with pushing borders, non-cohesiveness, small islands with narrow strands, and dispersed pattern, which is similar to the worst pattern of invasion in the AJCC classification, where there are individual cells, and these have prognostic significance. That just to recapitulate. And it's important to understand that invasion is a continuous spectrum. You evaluate the worst areas and you evaluate only resection specimens. We do not do that in an incisional specimen. And like I mentioned earlier, the RC path uses 2 broad groups of cohesive and non-cohesive. And the AJCC uses the worst pattern of invasion, grade 5, to see whether the prognosis is good or bad. This is important. I'm just going to show you a few examples. How exactly do you assess the depth of invasion? You have what's called the horizon, which is the line at the basement level. Very important, relative to the closest intact squamous mucosa. That would be that. That's the horizon line. And then you drop a vertical line down called the plumb line from the horizon to the deepest point of the invasion. And you measure this in millimeters. You have pre-formatted scales available for that. The reason why we use depth of invasion, not tumor or thickness, which is often discussed, and I think a few months back, Dr. Poyan made a good lecture in one of the series about how you measure this. If you look at the white line, that shows the tumor thickness, whereas the depth of invasion using the horizon and the plumb line shows the depth of invasion. So how you can see that you overread or upstage a tumor if you look at the thickness, whereas it's a little bit more appropriate and sort of goes hand in hand with the prognostic implication and value if you use the depth of invasion using the horizon and the vertical plumb line. That's okay for a straight surface, but in a tissue like tongue, where the surface is a little bit curved, then instead of using a straight line, you can use a curved line, and then you can drop a vertical line. By and large, any depth of invasion greater than 4 millimeters is considered to have a worse prognosis. If you look at the AJCC 8th edition, the depth of invasion is very important for the pathological staging of the tumor site. And the 5 millimeter and 10 millimeters are the cutoff points. Whereas T1 is less than or equal to 5 millimeters, T2 is between 5 to 10, and T3 is greater than 10 mm. So you have, these are the pathological cutoff points for the AJCC classification in the 8th edition. Perineural invasion. This is often underreported, and unless you look at it carefully, you may miss this. This is an independent factor for prognosis. In addition to node metastasis, local recurrence, and survival, this sort of influences all these factors. And you need to understand that when we say perineural invasion, you should have tumor cuffing at least 1/3 of the nerve circumference if it is perineural. Or sometimes you can get deposits of the tumor in the epiperi or the endoneurium, which is a sufficient evidence for neural invasion. And these tumors can spread intraneurally. And so you need to carefully examine all the sections to make sure that you document this, because this has a lot of implication in the prognostication of the tumor. Bone invasion is very important, especially in the head and neck region, because you have both the maxilla and the mandible close to the mucosa. And you need to make a distinction between medullary invasion, like you see on the left, and just cortical erosion. Why is that? A 2 centimeter tumor with just cortical erosion falls into the T1 category with a good prognosis. But at the same 2 centimeter tumor with medullary bone invasion goes into the T4 category, which has got the worst prognosis as far as the staging is concerned. So it is important that when you document bone involvement, it's not only sufficient that you call it bone involvement, but make a note of whether it's cortical erosion or medullary invasion. Let's quickly look at the variants in oral cancer, and these can be diagnostic pitfalls if you're not careful. Verrucous carcinoma. This is associated with chewing tobacco, like I mentioned at the beginning of this presentation. And chewing tobacco for very many years, particularly in older patients. It has these characteristic exophytic pattern with papillary projections, marked keratin plugging, and this is very important. It has broad pushing margins. And that's one of the way in which you can distinguish it from verrucous hyperplasia. The verrucous hyperplasia does not have these sort of broad pushing margins. And usually there is a very, very intense host response associated with this. So these are exophytic papillary projections with marked keratin formation and plugging, broad pushing margins, and significant host response. Metastasis is rare, but you need to be aware that there could be foci of squamous cell carcinoma within a verrucous carcinoma 15 to 20% of the time. So even if you diagnose verrucous carcinoma, it's imperative that you go through all these sections to make sure that you do not miss a frank squamous cell carcinoma occurring in a verrucous carcinoma. Then the treatment becomes a little bit more aggressive and the prognosis becomes different. Verrucous carcinoma per se has got a very good prognosis, very rarely metastasizes. Carcinoma cuniculatum, not a common lesion. It's derived its name from cuniculus, the Latin word for rabbit warren, the way the rabbits build their houses. And the lesion looks like that. It's very common in the gingiva. It presents as a warty mass. That's one of our cases. And you can see, reminiscent of the previous picture, these form these huge crypts, tortuous crypts filled with keratin. So, and clinically also they present as a warty mass. And histopathologically, you have keratin-filled crypts. You have broad pushing fronts, and you have a lot of tubular formations, from which it derives its name as cuniculatum. These are well differentiated. These are locally very, very aggressive. A lot of these have been reported in the cutaneous areas. They're not that common in the oral cavity. And these very, very rarely metastasize. And then you have the papillary squamous cell carcinomas. You need to be very careful with these because very many times, if you do not have sufficient history and you just get a small clipping of this particular area, you may miss out the fact that it's a squamous cell carcinoma presenting in a papillary or exophytic pattern. There is squamous differentiation. Sometimes as much as 70% of the tumor can have a papillary component. And being exophytic, there's very minimal invasion. may or may not be HPV positive. It's often P53 positive. Doesn't tell much because a lot of these tumors are P53 positive. But if you look carefully enough, you will see dysplastic changes within the epithelium of the papillary projections. You will see nuclear pleomorphism, mitosis, different sizes and shapes of the cell, and hyperchromatism. So you will see all the features which you'd expect to see in a squamous cell carcinoma. And these are restricted to the epithelium. But if you go deeper in, you can actually see the frank squamous cell carcinoma. So if you look entirely through the specimen, you will see areas which are frank squamous cell carcinomas, classic squamous cell carcinomas. The problem becomes, you face a problem when you have small incisional biopsies for the provisional diagnosis, and they can be really tricky. And in these situations, looking at the patient or having clinical information or a photograph can be extremely helpful. Basaloid squamous cell carcinoma occurs more posteriorly in the oral cavity. You don't see very many of them in the oral cavity region, which I sort of described the boundaries just a few slides back. They're more common in the hypopharynx, not that common in the oral cavity, and they're associated with extensive smoking and alcohol consumption. The surface areas will look like squamous cell carcinomas, and you go deeper, they'll have this typical basaloid epithelium. So this epithelium will be very similar to what you see in tumors like basal cell carcinoma, adenoid cystic carcinoma, basal cell adenocarcinomas, and some of these small cells can actually look like neuroendocrine carcinomas too. And when they occur in the pharyngeal region, you need to be careful because they can, you need to have these in the differential diagnosis. And you have cords, islands, and gland-like globules, and these have high nuclear cytoplasmic ratio like basal cells. And many of these may have these central necrosis, what has been defined as comedonecrosis. You may get mucoid stroma, which looks like secretions or like an adenoid component, but these are nothing but basal lamina material within the basaloid squamous cell carcinomas. These are high-grade cancers, and because they occur in the hypopharynx, a lot of them are diagnosed very late. And in fact, many of them are diagnosed when the patient comes for a routine examination and you see a lot of lymph nodal involvement. 80% have cervical metastasis at the time of diagnosis. Adenosquamous cell carcinomas, these can be tricky because they have components like this, which look glandular with secretions inside. So these are adenocarcinomas with squamous cell carcinomas. And of course, you need to keep in mind high-grade mucoepidermoid carcinomas. So these may not have mucous cells. And of course, we have now defined mucoepidermoid carcinomas by the CRTL-MAML2 translocation, or you can use the MUC1 and the MUC4 for high-grade and low-grade mucoepidermoid carcinomas by immunohistochemistry. These occur commonly in the tongue and the floor of the mouth in more elderly patients. The glandular component is more prominent in the deeper parts. Some of them may show intracellular mucicamine positivity. However, all of these are high molecular weight cytokeratin positive, and they are aneuploid. If it is a glandular tumor, you'd expect the lower molecular weight like cytokeratin 7 positivity, which does not happen in the adenosquamous cell carcinomas. And they have got poor prognosis. And fortunately, they're not that common, but if they occur, the prognosis is very poor. Acantholytic squamous cell carcinomas can be very tricky because you see all these small dispersing cells. They are very uncommon in the oral cavity, fortunately, and most cases occur in skin. And very many at times, they may have a pseudoglandular or a pseudovascular pattern. These usually don't metastasize. There were reports which stated that they are aggressive, but subsequently, this is open to question. And because we don't see very many of these in the oral cavity, we really do not know the nature of the lesion, but it's presumed that they're not that aggressive as it was initially thought to be in some of the earlier reports. And this shows, this is a reference from 2020. Very few lesions reported. If you're interested in looking at these, you can look at this particular manuscript. And you can see that many of them occur in the tongue and gingiva and floor of the mouth. And So these are not that common. Very few have been reported. Spindle cell squamous cell carcinoma can be tricky. And this slide is from my colleague and friend, Professor Anand Ramanathan from University of Malaysia. This is one of his cases, and he was kind enough to lend it to me. This is a very unusual variant, and these can be very, very tricky to diagnose. A lot of these occur during recurrence, particularly post-radiation recurrence. I put D differentiation in the inverted commas because I try not to use that term, but probably the recurrence, there's a lot of genetic changes. And one of the things which have been suggested is there is some alteration in the cadherin-catenin complex, which is responsible for these lesions having a mesenchymal-like appearance. These can occur in the lower lip, posterior lateral trunk, and the alveolar ridge. They often present as polypoid masses. Histologically, they have ovoid to spindle cells with significant pleomorphism and hyperchromatism, mitosis, but they are high molecular weight cytokeratin positive, indicating the epithelial origin. These frequently recur and metastasize, and they have very bad prognosis. The mean survival time is as short as 2 years. Of course, that's a positivity for high molecular weight cytokeratin. Okay, let me quickly go into some of the salient features of the most recent classification of the AJCC, which is being followed from January 2018. Okay, this is the sort of historical development of how this classification originated. The UICC had a separate classification in 1968. The AJCC came up with a classification in 1977. They combined together in 1987, and the most recent edition is the 2018. The primary premise is the anatomical extent of the tumor, and that's why you have the tumor. T stands for tumor size, N node, and M metastasis. This is very important for treatment decision, prognostication, communication of the data between people who are doing research from one clinic to the other, and for follow-up, and for cancer control activities. So you need a classification system which will help you do all this effectively, efficiently, and precisely. The important differences from the 7th edition are, first, the pharyngeal cancers have been split into 3 groups. You have one for the nasopharynx, which could be Epstein-Barr virus positive or negative. And the oro and the hypopharynx, you have HPV negative, and the oropharynx, you have HPV positive. So you have different criteria for these 3 separate groups. And there's a new paradigm for HPV-associated oropharyngeal cancer, a new set of criteria. There's a new staging for cancer of the oral cavity and the nasopharynx as far as T staging is concerned. And very importantly, there is inclusion of extranodal extension of the tumor, what's called the ENE. Some of the important caveats: diagnosis of all tumors should be confirmed microscopically. You have 2 types of TNM staging. You have what's called the clinical TNM staging, and you have the pathological TNM staging. And the clinical TNM staging goes to the oncology group for treatment. And once you get the specimen, you do the pathological TNM staging, and this can go into the prognostic group. And in this group, you can add non-core element data like presence or absence of HPV infection or P16 staining as a surrogate marker. If there is any doubt regarding the staging, always down categorize, use a lesser advanced or a lower stages assigned to that particular case. If you have multiple primaries of varying sizes, the multiplicity is documented, and the largest T size is taken for categorization. You can expand the category, or you can telescope the category, keeping into mind the major criteria. If you're doing some study and which you need more data, or you need lesser data, you can either expand it or you can telescope it, but keeping the fundamental premise in place. You can use additional descriptors like presence or absence of HPV infection. Now, this is very important. If a primary tumor directly extends into the lymph node, it is considered as a lymph node metastasis, even though there is a direct extension. And when you look at the pathological node size, it's important to remember that we're talking about the size of the metastatic tumor, not the size of the lymph node. And if there is a positive lymph node away from the drainage area, then it is documented as distant metastasis. And you can use the term micrometastasis for further stratification as MI. These are usually less than 0.2 centimeters. And then you have a staging called isolated tumor cells, where they are single or in clusters, which are less than 0.2 millimeters. These are not counted towards node categorization, except for melanomas and Merkel cell carcinomas of the cutaneous region. Some of the important differences are the depth of invasion is an important criteria in the T category, both clinical and pathological. T0 has been removed as far as oral cancer is concerned. Invasion into the extrinsic tongue muscle as a criteria for upstaging the tumor from T2 to T3 or T3 to T4 has been removed. It's no longer considered significant because we use the depth of invasion now. Cutaneous lip malignancies moved into staging for cutaneous cancer. Like I said, you have the wet zone and the dry zone. The dry zone falls into the cutaneous purview, and the wet zone falls into the oral cancer stratification. You have a separate neck clinical and pathological staging. And the next staging includes extranodal extension for upstaging the disease. So it's a very important criteria. Just a few more slides. Excuse me. And this shows that not only the tumor size or the diameter, but the depth is also taken into consideration. And like I said earlier, if it's T1, it's 5 millimeter or less depth of invasion, a 2 centimeter tumor. If it's T2, it's more than 5 millimeters, but no more than 10 millimeters. Sorry about that. 10 millimeters. So the cutoff is 5 and 10 millimeters between T1, T2, and T3. And of course, T4 is involvement of bone, skin, or the surrounding nerve, depending upon whether it's the lip or the oral cavity or a combination of lip and the oral cavity. So these are the new categorizations. TX when it cannot be assessed, T0 has been removed. TIS for in situ, MT for multiple primary tumors, NX when nodes cannot be assessed, N0 for known. You can use the term U and L for upper and lower neck category in the head and neck region. And then you have extranodal extension, presence or absence. And then you have microscopic, whether it's microscopic involvement or a macroscopic involvement. Clinically, the extranodal extension is decided by the skin involvement or soft tissue invasion, the deep fixation or tethering, and signs of nerve invasion. Whereas pathological extranodal extension is the extension of cancer from within a lymph node, bursting through the fibrous capsule of the node and spilling on into the adjacent connective tissue. And minor ENE is extension 2 millimeter from the capsule, and major greater than 2 millimeter microscopically. Or the pathologist can appreciate it with the naked eye when they are examining the slide. Extranodal extension is an important predictor of prognosis, except when those associated with human papilloma virus. Then the connotation does not carry as for a HPV negative tumor. So to quickly summarize, there is a distinction between oral cancer and oropharyngeal cancer. Oropharyngeal cancer is on the uprise in countries with a high human developmental index, and oral cancer is coming down in those countries. And 70% of them are associated with high-risk HPV, particularly HPV 16, for which you can use P16 as a surrogate marker. There is a difference between habits and non-habits associated cancer. And we are seeing an increase in non-habit associated cancer, particularly in younger individuals, without involvement of HPV in these situations. So a lot of work is going on in that field. And you need to make a distinction between viral versus non-viral oral cancer. And if there is the presence of a virus, you need to understand that presence of virus is not necessarily always infection. And infection does not necessarily always mean that it should lead on to oral cancer. For oral cancer to occur, you need integration, you need expression of certain genetic factors and epigenetic markers, and you also need them to escape the immune surveillance. You need a combination of persistent infection, integration, and ability to evade the immune surveillance. There are challenges in clinical diagnosis, and we saw quite a few cases highlighting that. The challenges to pathological diagnosis are not usually there as far as the diagnosis of a squamous cell carcinoma is concerned, except for the variants which we saw, and also the importance of two factors, particularly the depth of invasion, where we saw the 4 different types of pattern, and the 5th pattern recognized by the AJCC, and involvement of the nodes, particularly the extranodal expansion, both clinically and pathologically, and also the involvement of bone. You need to make a distinguishing note between cortical erosion and medullary invasion, which shifts it from T1 or T2 to T4. And this stratification is very important for both management and prognosis. And the purpose of all these classification is fourfold. One, which is very important, is what is called hazard uniformity. So each group has got a very, very similar risk factor, and something called hazard discrimination. So between stage 1 and stage 2, there should be definitely a distinct difference between the prognosis and the way the patient is going to respond to treatment. And the groups also should be structured in such a way that there is a balance of people falling into each group. You cannot have 90% of squamous cell carcinomas falling into one stage and the 10% being distributed in between all the other 3. And last but not the least, you need these staging groups to help you prognosticate as to how the patient is going to respond to treatment and how we are going to manage the patient and how we are going to follow the patients. So let me stop here by once again emphasizing the fact that oral cancer is distinct from oropharyngeal cancer, and cancers which have viral infection behave differently from those which do not have viral infection. And staging is very important for both hazard uniformity, hazard discrimination, making sure that there is an equal balance, or there's sort of a balance between slotting the patients in different stages, and it has a very important predictive value. So all these should be taken into consideration when you follow the staging to manage these patients. Thank you very much for your undivided attention. I think I've exceeded the time limit by about 5 minutes. Sorry for that.
Thank you very much, Professor Ranganathan, for your informative presentation. It was very, very interesting for me and also very practical. Thank you very much. There are a couple of questions because of the shortening of time. Let me ask you just one question. And the question is that in many cases of verrucous carcinoma, we only see pushing rhetoriges, but no frank penetration into basal membrane and invasion into the connective tissue. In such instance, do you feel it appropriate to still label it as a carcinoma?
Okay, I think this is the very, very important caveat, not only in cancer diagnosis, but in pathology per se. Never use one factor for diagnosis. It's very important that you realize that. So when I say verrucous carcinoma, I use a combination of factors. I use the factor that, it has got a verrucous surface, an exophytic surface, keratin plugging, and sometimes verrucous carcinoma, I see more mitosis than in a well-differentiated squamous cell carcinoma. Pushing margins and the reaction in the underlying connective tissue. And in fact, if you look into Ackerman's original article, let's call it Ackerman's tumor, when it was first described, there is yet another factor. If you get a specimen with the normal margins, when you look at the margin, you will see that there's a sort of a pulling margin between the normal mucosa and the verrucous carcinoma. It's a very classic curved cleft. And that's, if you get it, it's a good thing to diagnose verrucous carcinoma. And of course, when you club it with the combination of how it looks clinically and the habit which the patient has. So you take all this into consideration when you come to diagnose of verrucous carcinoma, because like you rightly asked, it can look pretty bland. So you need to be very careful.
Thank you. Thank you very much, Professor, for your informative presentation. I thank you again. And we will go to the next presentation. So this presentation is, we wish actually to the last presentation of today's session and also the last presentation of this short course. I am honored to introduce Dr. Puyan Amini Shaki. He is an oral and maxillofacial pathologist and associate professor in Oral and Maxillofacial Pathology Department in Tehran University of Medical Sciences, and also Vice Dean for International Affairs in School of Dentistry, Tehran University of Medical Sciences. The title of Dr. Shakib's presentation is Squamous Cell Carcinoma, Case-Based Discussion. Please, Dr. Shakib, the stage is yours.
Hello, everyone. Do you have my voice?
Yes, we can hear you. And also we can see your slides too.
Thank you very much. First of all, I would like to express my appreciation to Professor Ranganathan for his comprehensive and also impressive presentation. And also I would like to thank Dr. Mahtabi for your kind introduction. You know that I think it's very difficult and challenging for me to have the last presentation after interesting and impressive, I think 13 presentation by great professors, doctors, oral pathologists, well-experienced oral pathologists, and I will try to do my best in about 14 to 45 minutes. First of all, I would like to, as a part of organizing committee of this course, I would like to thank Tehran University of Medical Sciences and great contribution of Asian Society of Oral and Maxillofacial Pathologists. And also, I would like to thank Cancer Institute Hospital for supporting us, and also Apres to Raise team for their technical support during recent weeks. First of all, I would like to have a short introduction that where is my practice and where I do work in Iran. I am so delighted to let you know that I am a member of Oral Maxillofacial Pathology Department of Tehran University of Medical Sciences, and we have about less than 1,000 specimens per year before pandemic, and also we have mostly head and neck specimens, mostly incisional biopsies of oral cavity. Also, I'm honored to be a member of Cancer Institute Hospital, as our colleague and my professor, Dr. Azmude, yesterday will explain that the greatest hospital in Iran, and I think we have more than 2,000 specimens per year, and also something about more than 3,000 head and neck specimens, especially resections and excisional biopsies of the lesions. Also, in our center, in our referral center in Cancer Institute Hospital, we report intraoperative consultation for the surgeons. Also, it's a great pleasure for me to work in Danish Path Lab, one of the greatest private laboratory in Iran. And I would like to express that why I mentioned that I'm working in different centers and different labs, because I believe that this is a time for change for oral pathologists around the world. I know that a lot of oral pathologists around the world work in dental schools, but I think it is necessary for all oral pathologists to be in close touch with labs in hospitals and also in private practice, because it is necessary to be familiar with the problems surgeons, especially clinicians, oncologists face with during their routine practice in hospitals and also in private practice. Therefore, I encourage all of my colleagues around the world, especially who are attending this panel, to try work with clinicians all in hospitals and also in private practices. I think Professor Ranganathan well and comprehensive describe all other features of oral squamous cell carcinoma, but I try to share my experiences in 6 cases and let you know some details about how you can report a oral squamous cell carcinoma effectively to be useful for a clinician, especially head and neck surgeons. As you know, that oral squamous cell carcinoma is the 6th to 11th most common cancer worldwide, and as Professor Ranganathan well explained, that it is a leading cause of death worldwide. Approximately 94% of all oral malignancies are oral squamous cell carcinoma, and it is the most common cancer in oral cavity. The risk of intraoral cancer increases with increasing age, especially for males. Yes, and I prefer to separate my lecture in 3 different parts. At the first part, how we can make a definite diagnosis on incisional biopsy, and how can an oral pathologist play his or her crucial role in making a definite diagnosis. And at the second step, I believe that an oral pathologist should have the capabilities of reporting and consulting in intraoperative with surgeons. And at the last part, I will try to explain how we can have a well-descriptive final path report, which would be helpful for the surgeons and other clinicians. In the case 1, we have a 61-year-old male with tongue mass on the lateral border of his tongue, with more than 2 months duration and without any significant past medical history. Let's have a look at this specimen in low power. And the next one, the specimen, the incisional biopsy of the lesion with a higher magnification. As you can see, we have a highly cellular tissue with eosinophilic cytoplasm, mild cellular atypia, and hyperchromatism is evident in cells, in tumoral cells. And we cannot see a mitotic figure in this field, but it was evident in the specimens. Let's have a look at this. And a question arises. As professors well mentioned, that in oral squamous cell carcinoma, immunohistochemical staining is not helpful to make a definite diagnosis in a well-differentiated tumors, in a low-grade tumors. But when you face with high-grade tumors, commonly biomarkers will be helpful, and you should use biomarkers to make a definite diagnosis. And I will be grateful if you would let me know your answer, that which one will be helpful. Desmin, cytokeratin, leukocyte common antigen, or S100 for this case. If I would like to explain this case, I can mention, I can interpret this lesion as a poorly differentiated tumor, a small round cell tumor. Thank you for your answers. And my answer is all of these biomarkers. In fact, when you're coping with a poorly differentiated tumor, especially a small round cell tumor, as you well mentioned in chat box, you need to use desmin to rule out a rhabdomyosarcoma, and you need to use cytokeratin to rule out or rule in a squamous cell carcinoma poorly differentiated. And it is recommended to use CD45 or a leukocyte common antigen to exclude lymphomas and hematopoietic tumors. And also you can use S100 and also SOX10 to rule out melanoma, malignant melanoma. And let me share these photomicrographs of IHC stained slides. We used cytokeratin, pan-cytokeratin I1, I3 to recognize if it is a carcinoma or not. And you can see the diffuse membranous positivity of the tumoral cells, which confirm that you have the patient suffering from a carcinoma. Also, we can use P63 biomarkers, which is not specific for, in fact, for carcinoma, but you can use it for poorly differentiated carcinoma. And in poorly differentiated high-grade carcinoma, this marker shows diffuse nuclear positivity in tumoral cells. Also, we used Ki67 to evaluate proliferative activity of the tumors, and we reported more than 50% of the tumoral cells shows nuclear positivity for Ki67. And finally, we reported as a high-grade small round cell tumor with IC finding mostly in favor of poorly differentiated carcinoma. I use this table from Diagnostic Immunohistochemistry textbook written by Dr. David Dabbs, that he proposed that you can use these markers to for evaluating the poorly differentiated tumors if they are a squamous cell carcinoma or not. You can use pan-cytokeratin I1, I3, and also K903. I have not used this marker so far. Also, you can use, it is commonly used, cytokeratin 5/6 to diagnose a squamous cell carcinoma. Cytokeratin 7 is not commonly used for a squamous cell carcinoma because this marker actually shows positivity for ductal differentiation, and it is commonly used in salivary gland carcinomas. Also, you can use cytokeratin 8, 13, 14, 18, 19. Also, you can use CAM 5.2 and also epithelial membrane antigen, and also P53 and P63. And also you can assess the proliferative activity of the tumor using Ki67. As take-home messages, I can mention that squamous cell carcinoma are nearly always positive for cytokeratins. And you can routinely use these markers, I1, I3, and cytokeratins, including cytokeratin 5 and 6, and cytokeratin 14 and 17. And as I mentioned earlier, nuclear positivity of tumoral cells with P63 is obvious in a poorly differentiated squamous cell carcinoma, but it is not specific. I think professors in second day of this course well mentioned that P63 is also show positivity in myoepithelial cells. The most challenging cases that earlier mentioned we have with spindle cell carcinomas or sarcomoid carcinomas, which are not reactive with cytokratins in 30% of the tumors, but therefore it is a great challenge for the pathologist to rule out spindle cell, mesenchymal spindle cell tumors, and especially spindle cell sarcomas. And it is very important to differentiate spindle cell carcinoma from mesenchymal sarcoma, and it is very important for the clinician, especially surgeon oncologist, to design their adjuvant treatment. The next case is a 61-year-old female with leukoplakia on her tongue lateral border for 2 months duration and without any significant past medical history. Let's have a look at this incisional biopsy with low power. Excuse me. You can see an epithelial, overlying epithelium, a connective tissue, and also you can see elongated rete ridges, hyperkeratosis. And let's see the high power. With a higher magnification, you can see epithelial cells with cellular pleomorphism, especially nuclear pleomorphism. You can observe tumoral giant cell. You can see increasing nuclear to cytoplasm ratio and also hyperchromatism of the cells. I can make a diagnosis of severe epithelial dysplasia or carcinoma in situ, as Professor Tilak and Dr. Darakhshan well mentioned and present cases. And but my question is about what is the next step when you have such lesions, when you face with such lesions. What do you think a pathologist should plan for the next step? Do you recommend to have more recuts from the specimens, or you recommend to have IHC study, or you recommend surgeons or clinicians to prepare rebiopsies and send it to you, or surgical excision of the whole lesion? Yes, great. In fact, I do agree with you that it is necessary to provide more cut sections, because it is very, unfortunately, it is very common to have an invasive carcinoma in close areas to the severe dysplasia or carcinoma in situ, as you see in this photomicrograph. You can see an invasive great nest with prominent pearl formations, keratin pearl formation, and also you can see invasive small nests, including less than 15 cells, invading superficial striated muscular bundles of the tongue. Therefore, I do agree with you that in such cases, it is highly recommended to provide more recuts. As take-home messages, it is recommended to, in specimens, show severe epithelial dysplasia or carcinoma in situ, prepare more sections to rule out or invasive carcinoma. If clinical pathology correlation is in favor of invasive carcinoma, and after several serial sectionings you couldn't find any invasive carcinoma, you can think about recommending rebiopsy. It may not pleasant for surgeons or clinicians, but sometimes it is necessary to make an accurate diagnosis, and it is very important to schedule, to plan an effective treatment for the patient. As my colleagues, professors well mentioned, there's a challenge on moderate epithelial dysplasia. Some clinicians and the pathologists recommend to put the patients on follow-up, but most of the clinicians and pathologists advocates that to make a definite diagnosis based on clinical pathology correlation, or recommend rebiopsies. Okay, the next case is a 79-year-old male with a lip lesion at his commissural area with verrucous feature for more than 3 months duration, with no significant past medical history. I think the professors, Professor Tilak, Dr. Darakhshan, and Professor Ranganathan describe the challenges between verrucous carcinoma and squamous cell carcinoma, and I would like to emphasize on the importance of differentiating these lesions by this case. After incisional biopsy, you can see hyperplastic epithelium with elongated rete-ridges and bulbous rete-ridges, and significant crotin pearl formation, crotin plugging in overlying epithelium. And also it is obvious in higher magnification. But the challenge is about the nest, small nest at the tip of the rete-ridges. If these nests are invasion of the tumor to adjacent connective tissue or not, this is a this is the result of a cut sectioning. The important point, as Professor mentioned, is epithelial dysplasia. It is not common to have epithelial dysplasia in verrucous carcinoma, or we may have mild epithelial dysplasia or reactive epithelial dysplasia to infiltration of inflammatory cells in adjacent connective tissue. But it is common to have severe or moderate, at least moderate epithelial dysplasia in epithelium, in overlying epithelium in oral squamous cell carcinoma. Therefore, a question arises, what is your final diagnosis? It seems most of the audience are in favor of a squamous cell carcinoma, but it seems, unfortunately, I reported this case as verrucous carcinoma. I believe that this challenges is real challenge between oral pathologists, or even in one department, me and my colleague commonly have challenges to have to achieve a final diagnosis on these challenging cases, because I believe that a wide incisional biopsy with adequate depth is necessary to make a definite diagnosis to differentiate these lesions, to differentiate the squamous cell carcinoma from verrucous carcinoma. I don't prefer to emphasize on my diagnosis, and I modestly accept your diagnosis, but I would like to mention that several cut sections should be prepared to rule out invasive carcinoma. I didn't interpret the small nest at the tip of the retroregis as invasion. I interpreted them as just a cut of the epithelium, that they were not a real invasion to adjacent connective tissue from my viewpoint. And the important point is about reactive cellular atypia versus epithelial dysplasia, real epithelial, true epithelial dysplasia. Please be careful about differentiating these lesions, because reactive cellular atypia will eliminate it after elimination of adjacent inflammatory cells infiltrations. But epithelial dysplasia is a true premalignant lesion and should be treated if it is moderate or severe dysplasia. And as I mentioned, that the pathologic judgment is very important to differentiate if it is a tip of retroregis or a real invasive nest of a squamous cell carcinoma. The pleomorphism of the epithelial cells will be helpful to differentiate these two issues from each other. Okay, let's go to the second part of my presentation. After making a definite diagnosis, I would like to share some experiences on intraoperative consultation during surgery with surgeons when he or she is at operation room. When you have a specimen in fresh state from surgeon for intraoperative consultation, it is highly recommended to identify lesion meticulously and designate the distance from surgical margins, which commonly demarcated by the surgeon using silk stitches. At the second step, it is highly recommended to separate and dissect surgical margins, because it is very important for mostly important for the surgeons to know about involvement or not of the surgical margins by tumoral nests. After dissection of the surgical margins, it is highly recommended to have a cut sections through the tumors, to have both measure the depth, tumor thickness, and also prepare a cut sections for the frozen section study, because very important to have an overview of the grading of the tumor, especially squamous cell carcinoma. When you are coping with a poorly differentiated carcinoma, it is very difficult to make a diagnosis on intraoperative consultation. But when you have a well-differentiated carcinoma, it is not difficult to identify if surgical margins are involved by tumor or not. Therefore, as take-home messages, I think it is mandatory to have pathological report of incisional biopsy before frozen section study, because it is very important to know if it is a high-grade squamous cell carcinoma or not. As I mentioned earlier, that you don't have problem with well-differentiated carcinoma with prominent keratin pearl formation, but the problem is about poorly differentiated carcinoma. To make a definite diagnosis, if surgical margins are involved or not. And it is recommended to provide surgical margins before tumoral sections, because you are supposed to keep the structure of the whole specimens for upcoming dissections. Also, it is mandatory to provide tumor section to well assess surgical margins, and it is necessary to have a picture, an overview of the tumors. At the third step of my presentation, I would like to mention some important issue. Most of them was well described by Professor Ranganathan, but if you would let me, I will emphasize on these issues using some important cases. First of all, Professor Ranganathan well explained that several protocols are accessible for the pathologists to use to report cancer of oral cavity. But we commonly use College of American Pathologists in our center. It is including several sections, for example, procedure, tumor site, tumor laterality and focality, histologic type, histologic grade, specimen margins, also perineural invasion, lymphovascular invasion, worst pattern of invasion, and also pathologic stage classification. In the fourth case, we have a 47-year-old female with mandibular gingival ulcer for 1 month duration without any significant past medical history. Let's have a look at this incisional biopsy. You can see here something like granulation tissue with various size blood vessels, engorged various size blood vessels, and in the depth of the lesion, you can see tumoral nests. Tumoral nests show keratin formation, and also some of them show invasiveness to the depth of the specimen, and also you can see nests with prominent eosinophilic cytoplasm. Also, you can observe areas of necrosis in this specimen. And also you can see here nests with nuclear pleomorphism and also significant nucleoli. And the question arises that which grading system is more reliable? As well mentioned that we have several grading systems for oral squamous cell carcinoma, but the most popular grading system are Aneroth, Brine, Broder, and also other kind of grading systems. I will be grateful if you would share your experiences with us, which one you are mostly familiar with and which one you commonly use in your center. Great. I think in this case, yes, two brine system. Maybe Joe's mentioned that use others. And let me know, let me explain for you that we commonly use modified brine grading system, which including degree of keratinization, nuclear polymorphism, pattern of invasion, and lymphoplasmacytic infiltration. I think it is very feasible, it is very friendly for the oral pathologist to grade oral squamous cell carcinoma. In the first brine grading system, I think in 1989, we had also mitotic count in the grading system, but in the next grading system, it was omitted from the grading system, and we commonly use this. Therefore, I can recommend, we reported this case as a poorly differentiated carcinoma, and I can recommend you to use modified brine grading system, which is commonly used in several path lab and hospitals. Case number 5, a 53-year-old male with exophytic mass at floor of his mouth with more than 2 months duration and without any significant past medical history. We talked about this issue several times, but it is very, very important because, excuse me, you can see in this specimen, you can see in this photomicrograph that we have tumoral nests here in close contact with bone, alveolar bone. With a higher magnification, you can see tumoral nests invading bone here, and also tumoral nests invaded through the bone into medullary cavity. Professor Ranganathan well explained that it is very important to identify tumoral nests within medullary cavity of the alveolar bone to report a case as bone involvement and report stage of the case as T4. And we reported this case as a case with involvement of the adjacent alveolar bone. Let me share an article with you that's mandibular medullary invasion of oral SCC and is it necessary mandibular medullary invasion is in connection with prognosis of the patient, but erosion of the cortical bone is not directly well representative of the prognosis of the patient. And as take-home message 5, I can explain for you that the cortical bone erosion should not be interpreted as bone invasion. And the last case is a 32-year-old female with tongue ulcer on lateral border with non-significant, in fact, she didn't report it clearly her lesion when for the first time she could identify the lesion in her mouth. You can see here a lymph node which is involved by tumoral nests, small and great tumoral nests. It is actually completely involved by tumor with prominent keratin formation. But the important issue is about that extranodal extension should be meticulously evaluated by the pathologist, because as well mentioned by Professor Ranganathan, it has a great impact on the staging of the patient. You can see here that obvious extranodal extension invading adipose tissue surrounding the lymph node, and it should be reported by the pathologist. As you can see here, we reported this case as extranodal extension, which is very important for the clinician to well stage the tumor. And Professor Ranganathan will explain that extranodal extension, according to the recently published AJCC protocol and also College of American Pathology, change the stage and also pathologic and lymph node involvement from 1 to 2 and also from 2 to 3. And it seems that several sections must be prepared for metastatic lymph nodes to rule out or in extranodal extension. Let me share some cases and some experiences, articles with you about management of neck in oral squamous cell carcinoma patients. There are several cutoffs for the clinicians when a patient should be referred for neck dissections. In this article, a 2 millimeter depth of invasion is a cutoff to recommend a neck dissection at the tongue for the tongue tumor, and a 2 to 3 millimeter at the floor of the mouth, and at the retromolar trigone a 3 to 4 millimeter, and alveolar bone and hard palate is 3 to 4 millimeter. And for interpretation, for a conclusion, a 2 to 4 millimeter is recommended as neck dissection. And another article I would like to share with you that based on the findings, selective neck dissection should include 19 or more lymph nodes to have a well representative neck dissection report. And how about post-operative radiotherapy for oral squamous cell carcinoma with histologic risk factors? I would like to share this article with you, dear audience, that patients with multiple adverse pathologic features, including perineural invasions and also worst pattern of invasion 5 and also lymphovascular invasion in early stage oral cancer are more likely to benefit from in fact from post-operative radiotherapy compared with those with single adverse pathologic feature. And at the end of this lecture, I would like to invite all of you to have your experiences in make definite diagnosis, intraoperative consultation, and I encourage you to write and provide well-descriptive path report for all surgeons and oncologists. Especially, I would like to express my sincere appreciation to all of these great eminent professors kindly accepted my and our invitation to have very pleasant and impressive days with each other in this course. I think we need each other. In fact, I need all of you professors to have your experiences, because I believe that we need to make bridge between oral pathology around the world. Also, I appreciate this brilliant contribution between Tehran University of Medical Sciences and Asian Society of Oral and Maxillofacial, Asian Society of Oral and Maxillofacial Pathology. And I have a suggestion that we can continue this collaboration with monthly joint case presentation panel. I would like to express this suggestion with Professor Ranganathan, and I hope we would meet each other monthly in upcoming months. Thank you very much for your kind attention, and I will be grateful if there is any questions.
Thank you very much, Dr. Shakib, for the interactive and also informative presentation. I really enjoyed your presentation. It was very useful for me and very interesting. There are a few questions, and one of them is some staging system used by clinicians use the degree of differentiation. So she or he mentioned two staging system, TNM and AJCC. And the question is, which one do you prefer? Which one is the best?
I think, as Professor Ranganathan will explain, that we commonly the same the one grading staging system in which we evaluate all tumor size, lymph node involvement, and distant metastasis. And I think it is the same in AJCC, and also the AJCC use the same one. And I think UICC use the same staging system. But I will be grateful if have comments of Professor Ranganathan and also Professor Tilak.
Professor Ranganathan, we cannot hear you. You are muted.
Yeah, sorry about that. So you were asking which is the best system to follow. Was that your question?
Yes, the question is, which of the staging systems is the best, TNM or AJCC?
Yeah, the TNM is the AJCC system. The thing which you need to take into account is whichever you're comfortable working with, which you've been using for very many years. Each have your advantages and disadvantages. But if you're comfortable with using a particular system, you're going to do it appropriately and correctly. And I think it's very important that you're able to reproduce what you do. So all these systems are pretty good. So whatever works for your system, please use that.
Thank you.
And if it would let me, I would like to add one point that is very important. Yes, it's just, please, Professor Tilak, after you.
Yeah, AJCC and TNM, they are more or less the same. There is
Yes.
hardly any difference. But what is important is for all oral pathology departments to have a database using one of the systems. Either you can use Royal College of Pathologists UK one, or you can use the College of American Pathologists, or you can use freely available what we proposed, the International Collaboration of Cancer Reporting, ICCR. So that is freely available. If you go to the site, the data sheets are available, so you can download and start doing it. They all have the same thing. What is necessary is to maintain a database, which is not happening, especially in Asia. In most places, although oral cancer is very common, not many places in Asia, even the big oral pathology departments have follow-up data. And especially for Opmd, follow-up data is very less. And it's important because a lot of oral pathologists are listening to this. Country-wise, to maintain Opmd registries. Opmd registries are not available in most countries. If we want to see the natural history of Opmd into oral cancer, we need to have registries with follow-up data. So young pathologists who are listening, please make a note of it and use whatever the system you want, the database system, that's okay. But necessity is to have it. Thank you.
Thank you very much, Professor. Dr. Shakib, anything to add?
Would you let me add one comment? I think I think it is very important to be in close contact with your surgeons. It is very important to be in touch with them. They should understand what you are talking about, and it's very important to have something like tumor boards or meeting with them to share your experiences with them. And as you, Professor Mahdavi, well know that we have similar meetings with our surgeons in our school and in our hospital, and it is very important to be in close contact with the surgeons. Thank you.
Thank you very much, Dr. Shakib. And thank you for the presentation again. So now I would like to thank the keynote speakers, especially Dr. Ranganathan and Dr. Tilakratne for their wonderful presentation and also for accepting our invitation. I would like to thank you, Dr. Shakib and Dr. Darshan, for your informative presentation. I really enjoyed it. Yes, this is a certificate for Dr. Ranganathan. Dear Dr. Ranganathan, it is an honor for me to have you here in this panel and also to give you this certificate on behalf of our department as a sign of our appreciation for your wonderful lecture. Thank you.
Thank you.
It is my honor to present this certificate to Dr. Tilakratne. Thank you very much, Professor, for your accepting our invitation and for your nice, informative presentation. Thank you, sir.
Pleasure. Thank you.
Dr. Shakib, thank you for your presentation. I really enjoyed your presentation, and this certificate is awarded to you. Thank you again.
Thank you very much.
And finally, Dr. Darakshan, thanks for your wonderful case presentation. Thank you a lot. This certificate is awarded to you for your presentation. Thank you. Now I would like to explain
You are muted. You're muted, doctor.
Yes, you are. Okay, I'd like to, this is the last day of our short course. I'd like to say again that this short course was organized by Tehran University of Medical Sciences in association with Asian Society for Oral and Maxillofacial Pathology. So I would like to thank our colleagues in Asian Society for Oral and Maxillofacial Pathology, especially Dr. Mandana Dovugu and Dr. Simaprit Sandhu for their continuous support and help. And I also want to thank Iranian Cancer Institute and a Prize to Race group in the Office of International Affairs of School of Tehran University of Medical Sciences, and also the Office of International Affairs of School of Dentistry of TUMS. And also wants to add a comment because I saw some questions regarding the certificate and how the participants can get their certificates. I want to say that, as was mentioned in the registration form, certificates certificates of attendance will be awarded to those who participate for more than 70% of whole the short course program, and we will send this certificate via email for you within a month. Thank you very much. Thank you very much, Professor Ranganathan, Professor Tilakratne, for your presentation. and for being here today. And I would like everybody to turn on their webcams so we can have a group photo.
It seemed the last group photo of the course.
Yes, it's the last.
Oh, great. Great.
Thank you very much. Thank
Thank
you
you.
all.
All the best.
Thank you.
Have a nice day.
Bye-bye. Thank you.
Well done. Thank you very much.
Thank you very much, Professor. Thank you. Bye.